national scientists and KOLs who went through all the abstracts and then selected a few of them for the oral presentation divided between today and tomorrow, some for the poster presentation and some of course that we couldn't accept for either. Yeah, keep it open please. So we get going with the oral papers. The names of the presenters are listed for judging, and I wouldn't say chairing, for judging this session. We have two renowned judges joining us. Gives me great pleasure to invite Dr. N.K. Singh, senior physician and a cardiometabolic physician from Dhanbad, extremely academic oriented person, today far recognized for the CME course and the CME group of doctors covering more than 1,000 doctors now, Dr. Singh, 7,000 doctors across India and many joined in from outside. So everybody presenting, well, you're in for a tough competition with Dr. Singh judging the oral papers. Joining Dr. Singh, it gives me great pleasure to invite Dr. Navneet Wadhwa. Dr. Navneet Wadhwa um, has been an advisor to many of pharmaceutical companies. Today runs his own medical research and publication company, continues to champion the cause of people living with disabilities, including all hotels, convention centers, and getting people more sensitized to the needs of somebody with special needs. Dr. Wadhwa has helped many of physicians across the country with their data analysis and publications. So it gives me great pleasure to invite Dr. Navneet to join Dr. N.K. Singh as judges for today's sessions. Over to Dr. Singh.
Uh, Thanks, Manoj, I think, for the nice introduction for both of us with my co-chair, Dr. Navneet. I think without wasting time, I will invite Cynthia Sukumar. I think introduce yourself and her topic is diabetic ketoacidosis, a comparative study in type 1 and type 2 diabetes. I think this looks very interesting.
A very good afternoon to you. I'm Dr. Cynthia Amrita. I'm from the Department of Medicine at KMC Manipal. Today, I'm going to present to you details of our study on diabetic ketoacidosis, which is essentially a comparative study between the type 1 and the type 2 diabetics. So, what we know so far is that DKA is generally associated with type 1 diabetes, but it can also develop in people with type 2 diabetes, as recent literature has said. So DKA, as we know, is a hyperglycemia, ketonemia, and acidosis. And in the global scenario, literature shows us that over the past decade, there's a lot of studies that have been done on DKA patients between type 1 and type 2, but their numbers are limited, as in, so their sample size is quite limited. And in the Indian scenario, there's a lot of paucity of data to where they compare type 1 and type 2 diabetes patients presenting with DKA specifically. So what we did is we did a simple retrospective observational study on 348 diabetic patients in our hospital. And our objective was to look at the clinical features, the investigation profile, treatment outcomes in both these subgroups. Now, of the 359 patients that we screened, 11 were excluded, and we had 93 on the type 1 diabetic limb and 255 on the type 2 diabetic limb. And then we further collected data and analyzed them statistically. So our inclusion criteria was patient with DKA. DKA, as per the ADA classification, was glucose more than 250, pH less than 7.3, bicarb less than 15, and a moderate ketonuria or ketonemia. And our exclusion criteria was a euglycemic ketoacidosis. We ruled out pancreatitis and comorbidities like chronic liver disease and HIV. So we further took these DK patients and divided them into mild, moderate, and severe based on their pH, bicarb, anion gap, and their mental status, which was whether they were alert, confused, or drowsy. So this was our results. Our mean age, as expected, was a lot younger in the type 1 diabetics, and our type 2 diabetics who were presenting with DK, interestingly, were much older patients. And as the age progressed beyond 50, we had almost 117 of our patients in the 50 to 69-year age group. Though in the DKA group, we had an equal representation of men and women, we found that the male female ratio in the type 1 group was 2 is to 1 compared to 1 is to 1 in the type 2 group. Further on, the duration of diabetes also in type 2 diabetics was a mean of 7.6 years, where it was just 3.1 among the type 1 group. We further looked at treatment, and then there was a significant difference because most of our type 1s were on insulin alone, while our type 2 diabetics were tried on OHAs, then OHAs and insulin, and a lot of them were on insulin alone finally. So, what precipitated the decay? So, these are the spectrum of things that precipitated decay in these patients. So, right from missed insulin dose or OHA, right through the infections and heart failure, IHD, stroke, and even glucocorticoid use. So we looked at them in further in detail, and we noticed that among the type 1 diabetics, one of the top features for triggering DKA was a missed insulin dose or non-compliance. Whereas in the type 2 diabetics, it was more infection. So we had everything from skin and soft tissue infections, pneumonias, UTIs, and GI infections, which were triggering DKA in our type 2 diabetics. When it came to clinical features, as I showed in the previous slide, because a lot of them were triggered by infections, our type 2 diabetics presented with just fever, whereas our type 1 diabetics classically presented with osmotic symptoms, vomiting, abdomen pain, as we do see in DKA. The investigation profile in the type 1 diabetic showed a much lower pH with a wide anion gap compared to the type 2 diabetics. And the outcome was a little more interesting. When we looked at the number of patients who had died because of DK in the hospital, we found that there was a slightly higher percentage, a statistically significant percentage of patients who died succumbed due to DK in type 2 diabetics. But when we looked at the severity per se of the DKA, we found that the severity was more in the type 1 diabetic group. So, with these results, when we compare it to the literature that we found in the Western studies as well as a few scattered Indian studies, we found that in our study, we had a 73% representation of type 2 diabetics. When we compared it to the literature from the West, we found that there was a larger representation of type 1 diabetics in these groups. Further on, older type 2 diabetics with a higher BMI and a longer duration of diabetes were more predisposed to DKA. And this we concurred with evidence from the other studies also, where they said that large systematic studies as well as meta-analysis said that older type 2 diabetics with higher BMI are indeed more predisposed to DKA than type 1 diabetics when compared. We also found a smaller study from South India where they looked at 95 DKA patients, and they found that 80% of their population also were type 2 diabetics, and they were older type 2 diabetics with a longer duration of diabetes, as we saw in this study. As we mentioned, missed insulin dose and infections were the most common triggers, and across the board, through the papers that we saw, we found that this was consistent throughout in all their findings. Finally, when we looked at the investigations, we found the lower pH with a wider anion gap. Interestingly, a lot of larger studies, including large observational studies done on as many as 786 patients, did not really report a difference in the severity of type 1 and type 2 diabetics presenting with DKA, and neither did they find a difference in the pH or the anion gap. Whereas in our study, we did definitely find a statistically significant difference. This could be probably attributed to the difference in the sample size or the spectrum of patients presenting to us per se. So to conclude, the ketosis prone type 2 diabetics or the type 2 diabetics that presented with DKA were a majority of the patients in our study population. And importantly, older type 2 diabetics with an increased BMI and a longer duration of diabetes were more predisposed to DKA. So this is the group that we need to focus on, who are coming in to our clinics and our hospitals with infections, that we need to understand that these are the patients who could progress and advance on to DKA and present with DKA also. Non-compliance to medications and infections were the most precipitating factors. So there are a lot of patients who come to us with fever or infections which masquerade as DKA, and that's also something that we need to look out for in our Indian population. Again, when you look at the lab, we have a much narrower anion gap in our type 2 diabetics compared to type 1. And in this study, we found that the severity of DKA was more in type 1. But as I reiterated previously, the number of patients who died due to DKA in type 2 diabetics was more in comparison to type 1. Thank you.
I think discussion should now it will be better. So why did you exclude this EDECA? You didn't take any patient on the SGLT inhibitors.
No, sir, we did not, sir, because we thought that the euglycemic decay would complicate our study population. We wanted to look at type 1 and type 2 diabetics individually based on their clinical features and their demographics separately. So we did not look at patients on SGLT2 inhibitors. Therefore, euglycemic decay also was excluded, sir.
So what I find that the message from your study that more cases severe nature comes with the type 1 diabetes. Basically,
Yes, so the
it occurs in the
severity is
setting
more
of
in
type 2
type 1,
diabetes,
but
basically the atypical diabetes like ketosis prone diabetes.
yes, sir. We're talking about ketosis prone type 2 diabetes, sir.
But did you also look for the subtypes of ketosis?
So the thing is, this is just a part of my
Part of the
study
study, yeah,
findings,
yeah.
sir. So this is what I've presented for now. We're still analyzing the subgroups, sir.
Well, you well presented, I think. And Dr. Badhwa, any comment?
Any group of patients may not be in this data, but otherwise, are you intending to compare with SGLT2 as a benchmark?
So because in this group, among our patients, we have excluded patients, like I mentioned, with euglycemic decay. We have therefore, no, we have not included SGLT2 inhibitor separately, sir.
You are taking it as a confounding variable for this group?
Yes, because it could lead to euglycemic decay. So that's the reason. Yes.
Yeah, well done. Thank you.
Thank you, sir.
Next, I will request Malcolm Silva to present her. Achha, your paper.
Yeah, a very good afternoon to all. I'm Dr. Malcolm Silva. I am MD Pharmacology and currently working in medical affairs in Novo Nordisk. The title of my presentation today is Impact of Age on the Efficacy and Safety Outcomes of Once Weekly Insulin icodec versus Once Daily Insulin in Type 2 DM, a post-hoc analysis of onwards 1 to 5 trials. These are my disclosures. I am an employee of Novo Nordisk Private Limited and I hold shares at Novo Nordisk. This study was funded by Novo Nordisk and the onwards 1 to 5 trials. They were sponsored by Novo Nordisk and are registered with clinicaltrials.gov. So Novo Nordisk is a basal, so icodec is a basal insulin analog that is suitable for once weekly administration. It has been investigated in a global phase 3A clinical development program. This comprises of 6 trials. They are named as Onwards 1 to 6. Onwards 1 to 5 evaluated the efficacy and safety of icodec across a range of scenarios in individuals with type 2 DM. Majority of the people who are living with type 2 are older adults who are 65 years and older in age, and their prevalence within this group is increasing over time. Older adults with type 2 generally have more comorbidities than the younger individuals, and advancing age is associated with declining cognitive function, which can increase the risk of severe hypoglycemia. This post hoc analysis of onwards 1 to 5 assessed the treatment effects of once weekly icodec versus once daily basal insulin as comparators across different age groups in adults with type 2 diabetes. So the onwards 1 to 5, they were randomized control trials that were included. We included insulin naive trials, which were onwards 1, 3, and 5. We also had trials in insulin experienced subjects. Those were onwards 2 and onwards 4 trials. Here they had adults who were more than equal to 18 years of age with no upper age limit and with type 2 DM. So in all these trials, the participants, they were randomized in the 1:1 ratio to either receive once weekly icodec or once daily basal insulin comparators So which could be either degludec, glargine U100 or glargine U300. A mention of the onwards 4, which was a basal bolus trial. The participants in both the treatment arms, they also received 2 to 4 daily injections of insulin as part as the bolus component. In onwards 1 to 4 trials, icodec and the OD comparator insulins, the doses were titrated weekly based on the pre-breakfast self-measured blood glucose values to a target of 80 to 130 milligram per deciliter. In onwards 5, icodec was guided by a dosing app, and the OD comparator insulin doses, they were titrated at the investigator's discretion, which was as per the standard clinical practice. So these were the trial designs and treatments. Now, in this post-hoc analysis, the following treatment outcomes were assessed for icodec versus the OD comparators across 3 age subgroups. The age subgroup division was less than 55 years, between 55 to 64 years, and more than equal to 65 years. So the first outcome that was assessed in this post-hoc analysis was in terms of change in A1C from baseline to planned end of treatment, which was 78 weeks in onwards 1 trial, 26 weeks in onwards 2, 3 and 4 trials, and 52 weeks in onwards 5 trial. Secondly, they saw for the observed rates of clinically significant or severe hypoglycemia from baseline to the planned end of the trial, which was 83 weeks in onwards 1, 31 weeks in onwards 2, 3 and 4 trials, and 57 weeks in onwards 5 trial. Lastly, this also saw for the composite endpoint, that is achievement of A1C less than 7% at the end of treatment without clinically significant or severe hypoglycemic episodes in the previous 12 weeks. So now we move on to the individual outcomes of this post-hoc analysis. So first, these are the baseline characteristic where each of these onwards naive and the onwards insulin experience studies are being projected, and the parameters such as participant division, the male sex ratio, BMI, diabetes duration, and the A1C level that has been mentioned here in the form of the subgroup division. So we can see here all these baseline characteristic or the parameters were broadly similar across the treatment arms, across all the age subgroups. The first outcome in the form of estimated treatment difference in the change in A1C from the planned from baseline to planned end of treatment, we can see in this forest plot that the onwards insulin naive as well as the insulin experience studies across all the trials, the participants who were receiving the once weekly insulin, that is icodec, over the OD comparators had a larger or similar A1C reduction irrespective of the age. There was no statistically significant treatment by age subgroup interaction in the A1C changes. In the parameter of change in HbA1c, in the parameter where the combined clinically significant or severe hypoglycemia rates, we can again see here that the rates in the insulin naive and the insulin experience trials, that is onwards 1 to 5, based on the age subgroup division, and here they were low in both the treatment arms across all the age subgroups. In the onwards 4, we can see that the rates are numerically higher than onwards 1, 2, 3 and 5 trials, but they were consistent across the subgroups with no clinically relevant difference across the treatment arms. The next composite outcome of this post-hoc analysis, that was achievement of A1C less than 7% without clinically significant or severe hypoglycemia in the previous 12 weeks. So here we can see in the forest plot the superiority or the division in terms of the onwards 1, 2 to 5 trials. There was statistical significant difference in terms of HbA1c achievement of less than 7% without clinically significant or severe hypoglycemia. But there was no statistical significant treatment by age subgroup interaction for this composite endpoints in either of the age subgroups. So to conclude, Overall, the efficacy findings and hypoglycemia rates were consistent for once weekly icodec versus the OD comparators irrespective of the age. The estimated change in A1C in the icodec arm and the OD comparator arms from baseline to end of the treatment were generally higher for icodec, and the respective treatment differences were overall consistent across the age subgroups. The rates of combined clinically significant or severe hypoglycemic episodes in the icodec and the OD comparators, they were low and consistent across the age subgroups, and the odds of individual achieving the composite endpoint of A1C less than 7% at the end of the treatment without clinically significant or severe hypoglycemia were generally higher for the icodec arm, and their respective odds ratio, they were overall consistent across the age subgroups. So with this, I conclude the poster presentation.
Dr. Badwa, any question? I think this is a very important study as far as this molecule is concerned. We are still waiting that it will be launched in the India. I think next year it will be. I think you are an employee.
Yes, sir. So
Yeah,
hopefully we are launching by 2025 in India, sir.
yeah, in India. So as you are showing the odds here without clinically significant or severe hypoglycemia was generally higher for the icodec arm. Okay. So what is the exact message you want to give to the audience?
So the messaging from this poster in terms of the impact of age, we can say that this once a week insulin, that is insulin icodec, can be used in patients even in the elderly age group of more than 65 years without any compromise in either the safety, efficacy, as well as the odds of achieving a composite endpoint, that is HbA1c less than 7, along with that no or minimal risk of severe combined clinically severe or significant hypoglycemia as compared to a normal adult individual.
So you have presented this paper from the study all over the centers, or is it from a single center?
So this entire study, the onwards clinical trial program, is a phase 3 clinical trial program that is dedicated for the once weekly insulin icodec molecule. And after all these studies, individual studies, that is onwards 1, onwards 2, onwards 3, 4, and 5, once they were published in after the publishing in reputed journals, all the data was compiled and a post hoc analysis was done. That is after the studies were
That's
published.
you have presented.
Yes.
Okay, thank you. Okay, well presented. Thank you.
Yeah.
Uh,
Uh, So for now, we haven't got any data in terms of the cost. Subsequently, by 2025, we will get the label update from FDA. Post that, we will disclose the cost. So since this molecule hasn't been used anywhere, we cannot even give the approximate cost. But only thing we can say is we have to multiply it by 7. So the OD insulin dose per day of that patient multiplied by 7 would be the approximate cost plus or minus.
okay, so next I will request Dr. Sobhik Ganguly.
Thank you, everyone.
Yeah, thank you. Sobhik Ganguly to present the paper. Is the pharmacogenic and related factors affecting glycemic control in type 2 diabetes.
Yes. So give me one. मैंने जो दिया था वही वाला है कि पुराना वाला है? ठीक है, थैंक्स. Good afternoon, everyone. I'm Dr. Shovik. My study is pharmacogenetic and related factors affecting glycemic control in type 2 diabetes mellitus. The increasing incidence of diabetes is causing rising healthcare costs, morbidity, mortality, and diabetes-related comorbidities. Glycemic control is the most important predictor in type 2 diabetes related complications, mortality, and morbidity. Identifying factors associated with glycemic control will help to reduce the risk of diabetic related complications such as nephropathy, retinopathy, neuropathy, and cardiovascular and cerebrovascular diseases. With diverse phenotypic and genotypic features in type 2 diabetes, the one size fits all approach is inadequate. Multiple gene variants TCF7L2, PPARG, KCNJ11, etc. have been associated with glucose hemostasis and complex type 2 diabetes pathogenesis and its complications. Good glycemic control reduces the risk of diabetic complications. Despite this, achieving good glycemic control remains a challenge in diabetic patients. Several factors may be associated with adverse glycemic outcomes. In addition, multiple gene variants are associated with glucose hemostasis and drug response failure. It is therefore important to identify pharmacogenetic and other factors influencing the outcomes of glycemia. My research question was, is there an association between various factors, including pharmacogenetics, with glycemic control in patients with type 2 diabetes? The aim was assessment of pharmacogenetic and other factors affecting glycemic control in type 2 diabetes. The objectives were to evaluate the glycemic control status of patients with type 2 diabetes and determine the proportion of good glycemic patients, to examine the association between various factors, including pharmacogenetics, with glycemic control in patients with type 2 diabetes. Methodology, necessary ethics approval was taken. These were the inclusion and exclusion criteria. Evaluation parameters, glycemic profile status, that is the good and the poor glycemic control, socio-demographic profile, age and gender, socio-economic class, according to Kupuswamy socio-economic scale, anthropometric and metabolic profile, body mass index, lipid profile, disease profile, drug therapy and adverse drug reactions, medication adherence pattern, that is the Morinsky medication adherence scale. I had taken permission from the society. Diabetes self-care practices, diabetes distress syndrome, pharmacogenetic factors. We had taken 3 genes and 4 SNPs, that is KCNJ11, RS5219, TCF7L27, RSID79033146, RSID1225537, PRKD1, RSID 57803087. So these were my results. I could accommodate 121 patients in the past 8-9 months, and these were the graphs. The amount of good glycemic patients turning up in OPD was very less. We had around 83% of patients who were having poor glycemic control. The socio-demographic scale in the good in the age distribution, most of the ages were around 35 to 50. And in the good glycemic, it was 45% who were in the age group of 51 to 60. And in the poor glycemic, the majority was in the 35 to 50 age group. In the gender distribution, males were significantly higher in both good and poor glycemic groups. The socio-demographic scale, most of the patients coming in the OPD were in the upper lower group in both the poor and the good glycemic patients. BMI in the good glycemic group, the overweight patients were around 55%, whereas in the poor glycemic group, 60% were obese. These were the lipid values. The blood sugar values are as such that the poor glycemic group always had a higher blood sugar levels. The HbA1c values, the mean HbA1c value for the good group was around 6.59, whereas for the poor it was around the mean HbA1c value was around 9.63. The duration of diabetes we assessed, and for the good glycemic group it was less than 5 years for most of the patients, whereas for the poor glycemic we had almost the majority was in less than 5, then we had 5 to 10, and around 19% we had more than 10 years. For the age of onset, most of the patients were below, age of onset of diabetes, most of the patients had got their diabetes before 50 years. This was the Morinsky medication adherence scale. Most of the patients in the good group had medium adherence, whereas in the poor group, they had high adherence. Even then, it was difficult to have the HbA1c under control. The diabetes self-care practices, these are the values, and the total score was almost matched for both the groups. The diabetes distress, both the groups have very high distress. Most of the patients felt that they had some or the other problem, and they were mentally affected having diabetes. In the pharmacogenetic part of my study, we had 48 patients till now. We are trying to enroll more of them, and these are the genes. The TCF7L2, it is the most potent genetic risk locus for type 2 diabetes, and it affects insulin secretion and glucose homeostasis. Variants associated with type 2 diabetes risk influences the success of sulfonylurea therapy. So PRKD1 is implicated on various cellular processes, including metabolism. Alterations in PRKD1 activity are linked to obesity and type 2 diabetes development. KCNJ11, it echoes the KR6.2 subunit of the K-ATP channel in pancreatic beta cells. Mutations affect insulin release and contribute to type 2 diabetes. Variants may impair K-ATP channel closure and reduce insulin secretion. So unfortunately, we had very less good glycemic patients to be enrolled, and this is only we could enroll. But in the poor glycemic, we could enroll around 44 patients, and among them, so we can have the homozygous and heterozygous. And in the heterozygous of the first SNP, that is the 7903146, we had around 22 patients who had heterozygous. For the second TCF7L2, we had around 18 in the heterozygous group, around 22 who were, there were no polymorphisms. So that is the wild type. In the PRKD1, most of the patients who did not have. So in our population, PRKD1 was very less. Surprisingly, KCNJ11 was very high in both heterozygous as well as homozygous group. These are the percentages. So these are my conclusions. I'll directly go to the important parts, that is RSID 5219 variant in KCNJ11 gene was seen around in 50% of the good glycemic patients and 86% of the poor glycemic control patients. The RSID 57803087 we are not seen in any good glycemic patients, and we had only seen in 14% of the poor glycemic patients. The TCF7L2, both the RSIDs were almost around 64% in poor glycemic, 50% in good, and respectively in 1225537 50% in the good and 50% in the poor glycemic patients. So these were my references, my acknowledgement. Thank you. So I would like to say that we can consider placing the gene panel in our investigations as a secondary, or maybe for patients who are willing to go, because these are all high price tests around. So for me, it was around 6,500 per patient. So the expenditure is a little high, but we can see how we can include the gene panel, and we can study further and try to streamline our medications and stuff like that.
I think this study, although just gives, or you just given a glimpse as to how the genetic factors can influence the diabetic control. Definitely, there are many patterns. Even if you are using some sort of OHL like sulfonylurea, has got sometimes metformin is not tolerated to many patients. Again, there is some genetic factor for that. In the same way, but I think that KCN
KCNJ11,
I think neonatal diabetes
yeah,
is more important for
yes,
that.
yes,
But
sir.
you are just showing that in 50% of your those cases, it was present.
Sir,
But
we have
you have you compared whether someone is having this gene and this gene, two groups, was it statistically significant or not?
sir, further statistics is pending because we have not
Yeah,
completed enrollment.
yeah. So I think this study is not complete at all. But it is definitely a very good, could be a very, I think I will tell you a very important study in future if you complete it.
Yes, sir.
Dr. Badwa, what do you
I
think?
think it's a good attempt in terms of uh, drawing back the basic fundamentals. But has there been an attempt to look into the epidemiological reflections in terms of regional ethnicity? Will it be different?
Sir, we have very less studies, so I'm still working on it.
Yeah, yeah, it is. I think a very meager study has been done on this subject, especially in the type 2 cases. So I think still you have tried it. It is really, I congratulate you. Definitely, cost is a very, very important problem. In future, it could be that a genetic panel test you can do in 10 minutes in your chamber. So precision medicine is heading, but again, it is. I think it is again very. At least we can give some idea how this can affect the glycemic control. Thank you.
Thank you, sir.
Next, Dr. Amit is not there, so Doctor, I will invite Dr. Nadia Firozman. See there? Yeah, fine. So you talk on this antibiotic-induced persistent severe hypoglycemia in a patient with diabetic foot. Yeah, case report. Yeah.
Good afternoon to all in one year. I would take this opportunity to thank DRS, my colleague Dr. Hemant Kanse, who's helped me in this presentation, and above all, Dr. Argikar sir, who's been my mentor throughout. Um, we are presenting antibiotic-induced hypoglycemia seen in our patient back at Raheja. So we know hypoglycemia is a common adverse drug reaction associated with OHAs and diabetic medications. Occasionally, we know some of the antibiotics like quinolones do cause hypoglycemia, but the patient we are going to present who came in with severe hypoglycemia was due to TG cycline and linezolid induced. So we had a male patient, a 61-year-old male patient. He had a history of type 2 diabetes since over 15 years. He was on gliclazide XR60 twice a day, gliptin metformin combination twice a day, and AGI thrice a day. He was a hypertensive since over 15 years. He was controlled on bisoprolol and nicorandil. He was a hypothyroid since over 6 years, levothyroxine 50 he was on, and his TSH done in the hospital with us was normal. He had IHD history, 2 times stented in 2016. He was covered with statins and dual antiplatelets. He had a history of CA penis. Recent PET scan done in 2024 in Jan was normal. Lab cholecystectomy was done in 2017, and he had a history of pulmonary cox. 6 months of treatment were complete in the past. So he had come to us with severe peripheral neuropathy, right great toe gangrene, which was spreading to the adjacent toes. He had done his lower limb angio with DP plasty in another hospital and had come to us in around March 24. So on the 28th of March 24, he was admitted to us with the complaints I just shared. And since Feb 24, he had constant gastritis, vomiting, hiccups. On the 29th of March, the next day, he was operated. Right forefoot amputation was performed. Empirically, he was started on cifoperazone sulbactam 1.5 IV BD. Post-op, he had a lot of nausea and vomiting. He was treated symptomatically with ondansetron, domperidone, sucralfate, and baclofen. We investigated him, did a CT. The CT abdomen showed dilated CBD with no calculus. In view of the constant retching and vomiting, we called in the gastro team. A scopy was performed thereafter that showed gastroparesis, pangastritis, and duodenitis. Post-op cultures had grown Enterococcus fecalis and Klebsiella pneumonia. So according to the growths, linezolid and ceftriaxone sulbactam was sensitive. So we discharged the patient on both these antibiotics on the 4th of April. His anti-diabetic medications were reconciled and his dose of metformin was kept the same. Gliptin was removed, AGIs were removed, and gliclazide dose was reduced. On the 5th of April, he came in the next very day to the emergency department with complaints of slurred speech, facial deviation, irrelevant talk. His sugars at that time was 41. So he was started on IV dextrose fluids, pan infusions, a Ryle's tube was inserted. He was shifted to the ICU. The neurologist had come in to see him. There was no neurological abnormality. Routine labs showed mildly raised LFTs anemia, and hypoproteinemia. Immediately, ceftriaxone sulbactam was stopped. We started him on TG empirically. Linezolid was continued. Persistent hypos continued after that, in spite of withholding his OADs, and repeated dextrose salines D25s were given to the patient continuously throughout the day. He was on a 2-hourly sugar chart. He had continuous vomiting and retching, so we called in the gastro team again, who had advised an NG tube insertion. Even after we put in an NG tube, he couldn't tolerate his feeds. He had constant vomiting. Dextrose salines were on. SOS, around 18 corrections of dextrose were given in the span of 5 days. To rule out other causes of hypoglycemia, we went ahead and did the fasting serum insulin, cortisol, and insulin antibodies, which were all within normal limits. So on the 8th of April, we stopped the linezolid and TG. And on the 13th of April, his blood sugar started to stabilize and D5 correction was stopped. Liver enzymes came back to normal. Patient was discharged on the 15th in a stable condition. So these are the sugar charts for comparison. In the first admission, the sugars were all normal. He wasn't in hypos, he was on OHAs. This is during the second admission when he came to us with hypos. Continuously from admission on the 5th, he was on dextrose till about the 13th, 5 days after stopping the antibiotics, when his sugar started improving and he was kept off D5. So the patient experienced severe hypoglycemia, which resolved after stopping linezolid and TG cycline. Trend in hypoglycemic episodes had temporal association with the initiation of linezolid and TG cycline. Average T half of TG cycline is around 36 to 48 hours, which coincided with the time for the patient to improve after stopping the antibiotics. Likelihood of these antibiotics causing severe hypo is probable according to the Naranjo score 6. FDA adverse event reporting system demonstrated a relationship between linezolid, TG cycling, and the hypoglycemia. Hypoglycemia was associated with the use of linezolid and TG cycline, which is an uncommon occurrence. It can be very persistent and severe and often responds only to discontinuation of antibiotics like we saw in this case. However, the mechanism of action needs to be investigated further. Increased awareness can prevent significant mortality, morbidity associated with this rare but life-threatening condition. I would like to thank Dr. Irgikar sir and my fellow colleague, Dr. Hemant, in helping me in this presentation. Thank you.
Dr. Badwa, any question?
What is an element of newness in this research?
So, sir, TG cycline, we have read a lot about it, but I haven't seen many cases with hypoglycemia and TG. I have worked for 7 years at Raheja, but this was one case that we came across.
As compared
with
to
TG.
the literature and the
So-
FDA guidance.
Yeah, so as compared to the literature, it doesn't show a lot of TG cycline in studies. Yes, a lot of quinolones is showing hypoglycemia in our patients, but TG and linezolid is not very common.
I think these two molecules which we showed and you correlated it only,
Yes,
that this could be the region of the persistent hypoglycemia.
yes,
But there could be some other regions also apart from these antibiotics.
can be. So that's
Yeah.
why we ruled out the basic conditions through doing certain serum insulin, autoantibodies, cortisol levels. And since it coincided with the T half of stopping the antibiotics and then the sugars coming up, we thought this is the most probable cause.
So just the moment you they stopped it,
Hmm.
and after I think 48 hours, it
Yes, more than 48 hours.
more than 40 hours
Yes.
it took that it got so improving.
Yes, because his vomiting continued, everything else continued, but this was the change that we saw.
And have you got, although you showed that FDA has, there is
Yes,
some person showing that these two drugs, like linezolid and tigecycline, have been
correlated with
associated.
hypoglycemia.
So how many cases have been reported? Any idea?
No, sir, I wouldn't know that.
You don't
I'm
have any
sorry.
idea. Sir, can you comment, sir? 121. 21 patients so far reported. So the novelty of this paper, I can say that this makes us aware that sometimes if you get that persistent hypoglycemia, even after stopping the drugs, and taking care of other factors also, then if you are continuing these two drugs, this should be stopped. So this is a very, very important message from your study. Thank you.
Thank you so much.
It's a good signal. It's not
Yeah,
easy in
yeah.
our country to identify this.
So yeah, so that's a good one. Okay,
Thank you. Thank you.
thank you.
Someone's
So
mobile.
lastly, I will request Dr. Usha Rani Prasad. Uh, I think your topic has not been given here anyway.
Yeah. Good evening, everybody. I'm Usha, and I'm the medical team from Novo Nordisk. And I thank DRS and team for giving us this opportunity for oral presentation. So, my colleague Malcolm already has presented a post hoc analysis on the onwards trials. So, onwards trials are the ICODEC trials. So, I'm here presenting today the efficacy and hypoglycemia outcomes of the ICODEC, that is once weekly insulin, versus the basal insulins, that is the OD insulins, in type 2 diabetes based on the baseline GLP-1 RA use. Please note that this study has been presented in ADA this year, and I'm presenting here the encore. These are my disclosures. I'm the employee and hold shares there, and also the study was funded by Novo Nordisk and is being registered in clinicaltrials.gov. So my colleague has already given the gist of the trials here. Not moving. Just give me a second. Yeah. So as I said, we had 6 onwards trials in total. Onwards 1 to 5 were done in type 2 diabetics, and onwards 6 was in type 1 diabetics. And today I'll be presenting the post hoc on type 2 diabetics, that is onwards 1 to 5. Now, the question comes as to why did we choose to do this post hoc analysis? And also the endpoints here, what we defined were predefined before the onwards trials. Before the onwards trials. As we know that GLP-1 RAs are being well established and widely used in type 2 diabetes and have been recommended by the ADA, where the basal insulin can be added to GLP-1 RA therapies. So in this study, we aimed to assess the treatment effects of ICODEC, that is once weekly insulin, versus the OD basal insulins, compared basal insulin comparators according to the baseline GLP-1 RA use in individuals with type 2 diabetes. Now, talking about onwards trials per se. So now if you see, we have odd numbers onwards 1, 3, and 5, which were done in insulin naive patients. That is, these patients were not on any of the insulins prior to ICODEC or the comparator. And onwards 2 and 4 were the ones who were already on prior insulins, and then they were moved to ICODEC or the comparator. And one more point to note is that in onwards 4, it was the basal bolus regimen which was followed. And the participants in these trials were randomized 1:1 to receive either ICODEC, that is once weekly, or the or the basal insulin, which is OD. And among the comparators, we had Glargine U100, Glargine U300, and Degludec in different trials. Coming to the basal insulin titration here, they were titrated weekly based on the target of 80 to 130 here. And also to note that the pre-trial GLP-1 RA use here was recommended to be continued throughout the trial, and the participants were not stratified based on the baseline GLP-1 RA use upon randomization. Per protocol, the participants had to be treated with a stable dose of GLP-1 RA for at least 90 days prior to their screening. And we looked here in this post hoc analysis at the endpoints like estimated treatment difference in change in A1C from baseline to end of treatment, observed rates of clinically significant hypoglycemia or severe hypoglycemia, estimated proportion of participants achieving A1C less than 7% at end of treatment without clinically significant or severe hypoglycemic episodes in the previous 12 weeks. And also we looked at the insulin dose, that is estimated mean weekly basal insulin dose during last 2 weeks of treatment, and also looked at the body weight change from baseline to end of treatment. To note is that in this trial, from onwards 1 to 5, we had around 3,765 patients, people with type 2 diabetes, among which 801 were on GLP-1 RAs, and in icodec arm we had 400 of them, and in the OD comparator arm we had 401. And also the people with type 2 diabetes who were on GLP-1 RAs, they actually had the high HbA1c and also had the longer type 2 diabetes duration. Now, if you look at this plot, across all the 5 trials, the participants receiving the icodec versus the OD comparators had a larger or similar A1C reductions from the baseline to end of treatment, irrespective of the GLP-1 RA use. Note that there was no statistically significant treatment by GLP-1 RA subgroup interaction in A1C changes. So the A1C changes were similar despite the GLP-1 RA use. And next is to look at the clinically significant or severe hypoglycemia rates. And we saw that overall rates of clinically significant or severe hypoglycemia here were low across the treatment arms in onwards 1, 2, 3, and 5, irrespective of GLP-1 RA use. And you can note that the rate of hypoglycemia here, the event rate, is less than 1 per patient years of exposure. Whereas if you see onwards 4, the rates of clinically significant or severe hypoglycemia were similar between the GLP-1 RA users and the non-users in the icodec arm. Now coming to the composite endpoints, that is attaining the A1C of less than 7% without clinically significant or severe hypoglycemia here. So we see that in onwards 1, 2, 3, and 5, that is all the onwards naive participants, and 2, that is onwards 2, which was done in the insulin experienced participants. The proportion of participants here who achieved this composite endpoint was higher with icodec than with the OD comparators, regardless of the basal GLP-1 RA status here. There was no statistically significant treatment by the GLP-1 RA subgroup interaction for the composite endpoint. Now, looking at the basal insulin dose. Now, if you look at this, if you look at the icodec arms and you compare it with the OD arms in both the GLP-1 RA use and non-use, you see that the dose was high with the once weekly insulin. And also, if you compare icodec with GLP-1 RA use and non-GLP-1 RA use, the dose was high in the GLP-1 RA use. But also, please note that though we see that there was increase in dose here, there was no GLP-1 interaction seen. That is, you can't say that people who were on GLP-1 RA use had the significant insulin high dose. Now, looking at the body weight as well, if you see, we see that there's slight high increase in the body weight in the icodec arms compared to their OD arms. So, but also to notice that there was no No trial in this had statistically significant treatment by the GLP-1 RA subgroup interactions for change in the body weight from the baseline to end of treatment. So to conclude this post hoc analysis, we say that overall the efficacy and safety of once weekly icodec versus the OD comparators was generally consistent among the individuals with type 2 diabetes, regardless of the GLP-1 RA use at the baseline. And also across GLP-1 RA subgroups, there were no statistically significant treatment by GLP-1 RA subgroup interactions effects with respect to change in A1C. And also the rates of the clinically significant and severe hypoglycemia were low in the icodec treatment arms. And there were no statistically significant treatment by the GLP-1 RA subgroup interaction effects with respect to the proportion of participants who achieved this composite endpoint, that is HbA1c less than 7% without the hypoglycemia and change in body weight from the baseline to end of treatment. Thank you for your patient listening.
Well, you
Yep.
finished in time also. So I think the paper has been already presented at the ADA
Yes.
this year.
Yes.
So I'm not questioning about the ADA, the validity of the work. That's quite good. So what is the exact message from this paper?
So this paper is that, as the conclusion says, that the efficacy, the safety aspects
Yeah.
of icodec, and given the insulin dose and body weight change as well, do not differ with or without the GLP-1 RA
GLP-1
use.
RA. So this is, I
Yeah.
think, only thing important
Yeah.
message from this paper.
Yes.
Dr. Badwa, nothing. Okay, so I think the
Thank
session
you.
is closed now. So I think all you have done very well. And let us see, Dr. Badwa has given what a score. So that we will disclose to the organizers. Okay, thank you. Thank you very much for present. Thank you.
डेस्कटॉप ऊपर है फॉर्मेट
पे तो उड़ जाएगा ना और कोई किसमें रखे दूसरे स्पॉट में मेल कर दो
आपका भी लास्ट में व्हाट्सएप नंबर पर कर दो ना वो
कौन सा
9 वाला नंबर अमन करके आया
नंबर क्या है
देखो उनका से बोले यही है इसमें भेज दो आपका जब आपका लास्ट है ना स्टार्ट कर दूंगा
Good evening, everyone. Okay, so now we are going to start our in-hospital workshop management. And for this, I would like to invite Dr. Seema Bagrai ma'am and Dr. Manish Sachdeva sir to chair the session kindly. And our first speaker, Dr. Seema Bagrai ma'am, will introduce.
Good evening, everyone. We'll start with today's session, that is in-hospital management of a diabetic patient. This is a workshop which will be conducted by our 5 speakers. So I would like to call our first speaker, Dr. Vimal Pahuja from Mumbai. Sir will be taking...
Seema Bagri ma'am, apologies. Dr. Urvi Maheshwari ma'am is also here. She will be chairing the session too.
So we'll start our first session with Dr. Vimal Pahuja, who is from Mumbai, and he'll be taking us on management in the ICU, protocols and strategies. Over to you, sir.
Thank you so much. And it's a very, very important topic and workshop because hyperglycemia in the hospital is very common occurrence. And we see in day in, day out, but there are a lot of ifs and buts how to manage confusions and a lot of communication gaps and so many things. So people manage in their own ways, whichever way they like. But there are strategies, there are protocols which we can follow in the hospital, especially in the ICU. The succeeding speakers will be taking the other aspects of management of hyperglycemia in the ICU, the non-critical state. But I'll be just speaking about the hospital hyperglycemia in the ICU. So learning objectives will be to appreciate the importance of controlling blood sugars in the hospital, understand the targets, and learn about the IV insulin infusion protocols, which is very important. Monitoring of hyperglycemia in the critical care, how you do it. Future trends are there, but I will try to, if in the interest of time, if I have some time, I will definitely take this. So let's start a discussion with a case. As a 50-year-old male, he's admitted with a severe septic shock and an inotrope support and ventilator support as well. About to commence the test RT feeds. But his blood sugar is now 340 and A1C from the last records is 9.2%. How will you manage this patient? in terms of what targets you're going to keep, what is the strategy you will apply, how you monitor these patients, and how you switch these patients if you are starting the IV insulin therapy. So the prevalence of hyperglycemia is rampant, and this is a study which has been shown that hyperglycemia in the hospital is around 40% overall, when the ICU for all the patients is 32%. However, if you see the critical patients in the ICU, the hyperglycemia goes up to 70 to 80%, which is a very huge number. So hyperglycemia has to be treated. It's your another parameter which you have to take care of. Apart from blood pressure, the hyperglycemia is also very, very important. And mortality in the patients who never had hyperglycemia, never had diabetes, sorry, and hyperglycemia is very high. If you look at the patients who have diabetes, the mortality is very less, even if they come with the high blood sugars. But if the patient has got never got diabetes and he comes with a first onset, recent onset hyperglycemia, the blood sugars, the mortality is very high. And MICU mortality by the studies, you see multiplies 2 to 3 and fourfold as the blood sugars will increase. So that's been clearly showing that the mortality, it has controlling hyperglycemia has a mortality benefit. And not only the mortality we are talking about ultimate other outcomes, which are also going to be affected by the glycemic hyperglycemia. Glycemic variability is also very important, but hyperglycemia per se also can increase the risk of renal replacement therapy, need for mechanical ventilation, and shock. There's one important parameter which people may not be aware, which is called stress hypoglycemia ratio. If there's a stress hyperglycemia ratio, is what is it? It is the blood sugar which is now found out versus the A1C sugar, average sugar, and you take the ratio of that, and that is more than 1.1, then the mortality is very high. There's something called as glycemic gap. Glycemic gap is only for the people who already had a diabetes and now they have come with certain blood sugars. If the HbA1c average sugar and this sugar is more than 80, that is the patient's mortality rate is very high. So this are the new concepts are coming up. We should be aware of those glycemic gaps and stress hyperglycemia ratio. Now this is a very important thing why the hyperglycemia happens in ICU. Very simple, that you are exposed to the stressful milieu. There is a lot of insulin deficiency, insulin resistance, counter regulatory hormones coming into picture. And what happens because of that? Adipose tissue starts breaking down and causes lipolysis, which all thrown into the liver. Liver produce glucose all from all of the lipids which have been thrown in the liver. And proteins, muscle will also start breaking down. So you get a lot of hyperglycemia. To add fuel to the fire, you have IV fluids, you have steroids, you have enteral and parenteral nutrition. You also have, because of this hyperglycemia, there is a circulatory and hemodynamic effects which are going to come. Electrolyte effects are going to be there. There's a volume overload. There may be sometimes hypotension, or there could be dehydration, and there are tissue effects also seen. So all these things, because of so many changes, there's a platelet activation, there's endothelial dysfunction. This can contribute to sepsis, multi-organ failure, and death. It's not itself going doing that, but yes, it is definitely going to contribute to all these things. Let's be aware about some definitions in the hyperglycemia in the ICU. Any blood sugar more than 140. Stress hyperglycemia is there when the blood sugars are more than 140, but your A1C is less than 6.5. A1C more than 6.5 always is causes a predefined diabetes, which was already there but not picked up earlier. Hypoglycemia, any hypoglycemia less than 70. Severe hypoglycemia is less than 40 milligram deciliter. These are the hyperglycemia or hypoglycemia definitions in the hospital. Now, ACE and ADA recommendations for all critical care patients, targets are 140 to 180 strictly. Intravenous insulin infusion is preferred, and hypoglycemia has to be looked into. And whenever the blood sugars go less than 100, you have to reassess your therapies. Reassessment and modification targets for hypoglycemia on hyperglycemia also should be individualized. So this is very important. Hyperglycemia, you have to control but avoid hypoglycemia, and lower targets less than 110 associated with increased mortality due to hypoglycemia, shown with the lot of studies, which I'll come to this. Contrasting outcomes. People were very happy with the surgical ICU study by one day 2001, and this showed that less than 110 to 140 target was associated with the less mortality. However, nice sugar study in 2009 put everything at rest, all the arguments at rest, showing that mortality increases and there's more episodes of hypoglycemia if you use tighter control. So after that, there has been no argument that you should not be doing, lex target of 140, 180. Everybody agrees to it. And now tighter control has, many other studies have shown very high death risk. So you should prefer this 140 to 180 targets, which is a right target for our patients. Continuous insulin infusion protocols are standard of care and requires frequent monitoring. And titration of insulin is based on bedside glucose readings. So monitoring is also very important, and 1 to 2 hourly monitoring, depending on the protocol, is required. Components of IV insulin therapy: concentration should be standardized throughout the hospital. Regular insulin or analog insulin, as per the preference, you can use concentration of 1 unit per ml or zero 0.5 units per ml. Dedicated IV route should be given, and infusion controller adjusted to 0.1 unit doses should be used for the IV insulin therapy. Accurate bedside monitoring is important. Every 2 hourly, depending on the protocol, sometimes you have to do 1 hourly also, and 4 hourly, sometimes the patient is stable. And potassium should be normalized before you start insulin. Look at the potassium, normalize the potassium, and then start the IV therapy. If you see, the protocols are multiple. Yale protocol is the most preferred protocol and being used. There's another system which is called glucomandas system, which is a computerized based protocol, which also has been in vogue in West. We don't have here. However, Yale infusion protocol is simple protocol to adapt if somebody wants to do it. It's a very simple protocol. You can see the clear instructions for the initiating insulin infusion. You have to round off you have to divide the current blood sugar with the weight of the patient, and you can see divide by 100, and you can see the what is the figure, and that according to that you can start the infusion, and then you start monitoring the patient. And there are clear instructions for hypoglycemia or stopping the infusion rate here. And you have to take the another step, look at the patient's blood sugar current and put it in a particular column, which has been shown here. Either it is 70 to 100 or 140 to sorry 100 to 139, and or more than 200, whichever column he belongs to. You to start from that column, and the next all blood sugar you have to deduct from the previous blood sugar, and whatever is a change, according to change, that change you have to change the insulin infusion. So these instructions are very clearly laid out here. Of course, your staff or nursing should be skilled enough to understand this. That's very challenging. In India, practical problem is that our nursing staff is not that well equipped in terms of skill to understand these nitty-gritties of the protocol. So optimal protocol should be validated and maintains the blood sugar successfully within a pre-specified target range, with maybe 4 to 6 hours. And clear algorithm should be there for changes in the IV insulin rate. And rate of change should be incorporated, not in terms of only blood glucose, but it should also look at the delta change from the previous blood sugars. According to that, you have to maintain the change and incorporates the current in IV insulin rate, minimizes hypoglycemia, provides specific direction for its treatment and when it occurs. IV insulin key points are there are many protocols, but you you have to individualize your protocol. You can use your own protocol, right? Ideal protocol will be that will work for your institution, and other protocols are also needed to manage hypoglycemia and how to switch from IV to subcutaneous therapy. So there is something about using a long-acting insulin, basal insulin, along with IV insulin. And there is one study published which have showed that if you use a basal insulin with a protocol, IV infusion protocol, there's much better way of much better, because rebound hyperglycemia is prevented when you stop the insulin infusion. Length of stay goes down, and you can achieve the target faster without much risk of hypoglycemia. So there is some evidence to it that you can use long-acting insulin plus IV protocol. Transition to subcutaneous insulin. My other succeeding speaker will be speaking about it. But when you are talking about IV, stopping the IV, you should see the patient is stable in eating, and he should be having steady blood sugars for last 3 to 6 hours. And basal bolus regimen always we recommend when you want to stop. You give a basal 2 hours prior to stopping the insulin infusion protocol. The SAHA protocol, which we have used, I have made the protocol for our hospital. It's a column-to-column protocols, and there are rules which have been laid out for the change in the blood sugar. So every 2 hourly, the sugar, we monitor the sugars, and according to the change in the blood sugar, they have been instructed to change the protocol or the column, and this is the way how we monitor the patients. So glucomandas system, on one word, very important, because computerized based system, and now the AI based algorithms are going to come, and they are fantastic because they have achieved a much better success in terms of blood sugar target range, and it is automated So staff will not have confusion and reduce the errors and have a much better risk of reducing the hypoglycemia risk. So this is what it is. It's very important that, and it reaches the target very fast. It reduces the length of stay, and it is very important to automate the systems because manual errors are common with the staff. And monitoring you can do, it's SMBG is very important. We know there are caveats, vasopressors, high paracetamol therapy, all these things can interfere with the blood sugar. If you're not sure about your blood sugar, verify with either arterial blood gases or send a random blood sugar sample to the laboratory, and then you can calibrate your blood glucose monitors. CGM is one of the things which people are started using. However, there's a CGM lag time, sensor accuracy, and calibration is needed for these kind of experiments if you want to do, because the scoping review which was published in current diabetes report recently showed that it's a very good boon for the staffing nurse. In 2019 it was a boon, or after 2019, because the COVID came and people started using CGM in the staff in the ICU. But it is requires a lot of calibration, a lot of training and integration into your system. By my standards, I've used some patients on CGM in ICU, but I use a hybrid mode, SMBG word and CGM together, and then it can give you better results. Successful strategies, there should be a champion, there should be a lot of administrative support to do this, and multidisciplinary team should be there. You should be recurrent training, and you should have to revisit the protocols and change again and again. A lot of people are involved in this kind of a activity. Assessment of current processes, quality of care, barriers to practice to change, because people don't want to do, everybody wants to do sliding scale. A lot of things are required. I had a hard time using, putting the protocol in process. So summary is hyperglycemia is common, is very common, and it is a predictor of severe outcomes, including mortality. Significant improvements in mortality and morbidity with intensive glycemic management have been demonstrated in some randomized clinical trials and in before and after comparison, and mixed medical and surgical ICUs. 140 to 180 target is very reasonable, and IV insulin is a preferred therapy in the critical care setting. Thank you so much.
Thank you, sir.
And my
Question
we
session
should
will be
take
taken
after. Yes, yes.
at the end of the workshop.
So now I would like to call upon our next speaker, Dr. Mohsin Aslam, who will talk on planning shift outs and transition to subcutaneous injections. Welcome, sir.
Good evening, all, and thank you, ma'am. I would like to thank the organizing team, DRS, Manoj Chavla sir, and Purvi ma'am for giving me this opportunity. So, Dr. Vipul sir had Vipul sir had showed about how we manage the patients in critically ill patients in ICU with IV insulins. And now, once the patient is stable enough, started eating, we need to shift the patient from IV insulins to subcutaneous. So how do we do this process? We see that when to shift the patient and how do we shift the patient in the coming slides. So we all know inpatient hyperglycemia management is totally a different thing from what we do in daily outpatient basis. And patients with diabetes have 2 to 6 times higher hospital admission rates when compared to normal patients. And again, inpatient management can pose hospital specific challenges. Like as sir said in the slides, like multiple injections monitoring are needed, continuous monitoring is needed, and it's a very difficult task. The staff to be trained. This is possible in ICU settings, but not in non-ICU settings. And also the targets references are different in different sets of patients. Patients who are critically ill, we just try to be lenient because even we have to prevent hypoglycemia. Younger patients, we have very stringent, tighter targets. And then comes a phase of transition again, which has to be decided which patients can be shifted to subcutaneous insulin and when. So again, managing hyperglycemia in hospitalized patients, we have choice of OADs and insulin, but again, OADs are not preferred because patients are not taking orally or may have other acute kidney injuries or a septic condition where they may have adverse events. So insulin is recommended. And again, if a patient is critically ill, admitted in ICU, then we prefer giving IV insulins. And if patient is stable enough, we prefer subcutaneous insulin, particularly basal bolus insulin. So what do the guidelines recommend? So ADA and AS suggest switching the continuous IV insulin to subcutaneous insulin when medically appropriate. But
However, ASPEN guidelines make no recommendations on the transition methodology. Now coming to the principles of transition from IV to subcutaneous insulin. So conversion to subcutaneous insulin therapy should be postponed until the volume resuscitation or pressure support can be discontinued and the patient is ready to resume eating. Scheduled subcutaneous insulin therapy should meet both basal and nutritional insulin requirements and should also include correction dose for hyperglycemia. Subcutaneous administration of insulin should be initiated at least 2 hours before discontinuation of the IV insulin in most of the patients to prevent rebound hyperglycemia. Starting basal insulin in the form of long-acting peakless insulin along with the IV insulin also helps in early and easy transition to subcutaneous therapy. So now, what are the indications that the transition from IV to subcutaneous insulin is advantageous or safe? Well, first is the stable blood glucose levels. That is, patient is maintaining blood glucose levels between 140 to 180 milligram per deciliter for at least last 4 to 6 hours. Patients, there is a resolution of acidosis in DK and normal anion gap. Patient is hemodynamically stable and off vasopressors. Patient is on stable nutrition plan or is taking orally, and his stable IV drip. That is, patients usually those whose last 4 to 6 hours blood glucose levels are below 140 milligram per deciliter with a stable infusion rate and requiring very less insulin, that is less than 2 units per hour, they are more successful to be transitions to insulin, subcutaneous insulin. Now, again, sir has shown that the management of IV insulin is very cumbersome and requires a lot of efforts. And this is one of the disadvantages for IV insulin in non-ICU wards. So transition should be made only when it is clinically and logically appropriate and patients exhibiting signs of stable glycemic control. So you can see this table here. In the last 6-8 hours, the patient's insulin requirement is stable, and that is very low, around 0.6 to 0.5 units per hour, with along blood sugar levels also being stable, maintaining between 130 to 140. So this patient is safe enough to be transitioned from IV to subcutaneous insulin. So now, what are the indications that patient it is not safe to start the patient on subcutaneous insulin? Once the dip rates variability is very high with very high fluctuation in sugar levels and patient requiring very high dose of insulin. Also, patient on IV insulin for less than 6 hours. So it is not appropriate because it doesn't give the exact idea of what is the exact requirement of insulin for the patient. Again, this table shows that there is a lot of variation in the blood glucose levels and blood insulin requirement. So this patient is not an ideal to shift to subcutaneous insulin immediately. So now consequences of premature transitions. Problems arise when discontinuing the infusion when it is not appropriate to discontinue, or discontinuing at a safe time but making logistical errors so that the transition fails. So what are the consequences? There's a rebound hyperglycemia. There's a failure of transition, that is patient may again require IV insulin, or in select cases it may result in activation of again DK. So what are the predictors of poor transition? Elderly patients, there are wide fluctuations in the blood sugar levels requiring frequent stopping of the insulin infusion, poor admission HbA1c, complex surgical procedures, intensive care unit settings, and patients on corticosteroids. So now coming to the process of transition. A properly planned transition requires that the first dose of subcutaneous insulin is administered at least 1 hour prior to discontinuation of the infusion so that we prevent the rebound hyperglycemia, and this is more common in patients who are having endogenous insulin insufficiency. So administration of subcutaneous basal insulin as early as possible, that is at least 7 hours prior to discontinuation of the IV, helps in preventing the future rebound hyperglycemia without increased risk of hypoglycemia. So now what do RSSDI, our Indian guidelines, say? To prevent recurrence of ketoacidosis or rebound hypoglycemia, consider the overlap of IV insulin with at least rapid acting insulin given 15 to 30 minutes before stopping infusion, or regular insulin given 1 to 2 hours, and long acting insulin given at least 2 to 4 hours before stopping the IV infusion. The most convenient time to change to subcutaneous insulin is pre-meals, and for patients who are already on insulin, following the old regimen with just adjusting the dose of insulin dose is needed. So now components of subcutaneous insulin regimens. The subcutaneous insulin regimen that replaces the IV insulin should cover both basal and mealtime insulin requirement. So, total daily dose of scheduled subcutaneous insulin therapy is assigned conservatively for most patients to be approximately 80% of the total daily dose 24-hour requirement. Correction doses are given by rapid acting analogs, and it's given when the target sugar levels are more than 180 milligram. Sorry, when the sugars are above target and it is more than 180 milligram per deciliter. So now calculating the total daily dose of insulin requirement. So for a safe transition, numerical assessment of IV insulin requirement is needed. The amount of insulin infused by drip in 24 hours cannot always be assumed to be the actual 24-hour daily requirement by subcutaneous for the transition. So for that, to calculate total daily dose, calculate the insulin needed for the stable glycemic control over last 4 to 6 hours, for 6 hours and multiply by 4, or calculate the total dose needed for last 24 hours and consider to take only 80% of this dose and divide as 50% as basal dose and 50% as bolus into 3 divided doses. So now determining the correction dose. To determine the correction dose, one must estimate how much blood glucose level is lowered by 1 unit of rapid acting insulin. This factor is known as uh, correction factor or insulin sensitivity factor and is estimated by dividing 1800 by total daily dose. And on an average, 1 unit of rapid acting insulin lowers the blood glucose levels by 30 to 50 milligram per deciliter. Now the formula to calculate the correction dose is actually measured blood glucose minus target blood glucose divided by correction factor. Suppose total daily dose requirement is around 60 milligram units per day, then the correction factor becomes 1800 divided by 60, so it's 30. And the blood glucose level measured is 250, and actually what the target is 100. So difference is 150. 150 divided by 30, so we need to add a correction dose of 5 units. So, but again, this is not possible for all the staff to calculate. So we can just make a simple protocol, keeping target as 100 to 140, and anything above 140, keep adding the subcutaneous dose as a correction dose. So normal patient, we can add 4 units for sugar levels between 140 to 180. And after that, for every 40 increase in blood glucose levels, keep adding 2 units to the fixed dose. If the patient is insulin sensitivity or having frequent hypoglycemia, you can start with 2 units and then keep increasing by 2 units. In patient who is insulin resistant, obese or on steroids, you can start with 6 units and keep adding 2 units for every 40 milligram increase in blood glucose levels. So in patients with who are nil orally, so ideally you should not shift the patient to subcutaneous insulin, but certain patients might need to be transited because of the logistics. We are not able to measure frequently sugar levels. So what we can do is calculate the last 6 hours, what is the insulin requirement. So suppose in this patient, the last stable glucose insulin requirements are 2 units per hour. For last 24 hours, it is 48 units. So out of that, 80% is 38 units. So you can give that entire 38 units as subcutaneous basal dose and monitor sugars once in 4 to 6 hours. So a patient who is already eating, again, you can see this patient's average insulin requirement was 1 unit per day. So total for 24 hours, it is around 24 units. So 80% is 19 units. But as this, you can see the time it was measured during the overnight fasting period. So give this entire unit as 19 units as basal dose, and for Prandtl, give weight-based calculation. So weight-based calculation, you can give like small dose because a patient might not be taking adequately 0.2 units per kg for total Prandtl dose. Suppose a patient is 80 kgs, so it comes to around 16 units per day. So you can divide into 3 meals as 5 units per each meal. So it will be like basal units of 19 units plus 3 units, 5 units per 3 meals plus correction dose we have to add it. So monitoring and reviewing. So first 24 after transition is crucial to assess the patient's insulin requirement, as this may continue to change the clinical improvement. Blood glucose should be monitored at least 5 times daily, that is pre-meals and bedtime, and once at 3 a.m. The half-life of IV insulin is less than 5 minutes. So to prevent rebound hyperglycemia, we need to start subcutaneous insulin at least 2 to 3 hours before discontinuing the IV infusion. So to summarize, when discontinuing intravenous insulin, a transition protocol is recommended. Subcutaneous basal insulin should be given 2 hours before intravenous insulin infusion is discontinued with the aim of minimizing rebound hyperglycemia. For transitioning, the total daily dose of subcutaneous insulin can be calculated based on the insulin infusion rate during the last 6 to 8 hours or based on the prior home insulin dose or following a weight-based approach. Thank you.
Thank you, Dr. Aslam.
Now I would like to call upon Dr. Akshay Kothari. He's a diabetologist from Andheri and my dear friend. He'll be taking us on management of diabetes in wards.
दूसरा था दो था बोला भी था डिलीट कर देना जो है एक मिनट ये वाला है मैनेजमेंट इन द वर्ड्स ये वाला है फाइनल देख लेता हूँ दिस इज द वन थैंक यू So at the outset, I would like to thank Dr. Manoj, Dr. Purvi. Thank you, chairpersons, for your kind introduction. And good afternoon, everyone. So my talk is made easy by previous two speakers who have already spoken about many things which I am going to take. So I might skip few slides. So my talk today is management of diabetes in the wards. So first thing is individualization is the key. So insulin therapy for all may not be appropriate. However, some patients may be managed with a combination of insulin with OADs, and many patients may require basal plus therapy, and some of them may require basal bolus therapy in the wards. It is different in the ICU as compared to wards, so you can manage some stabilized patient without insulin as well. Second thing, I will speak something which Dr. Vimal already had spoken, use of technology and glucose monitoring, which we can incorporate in wards to some patients. So main thing is individualization. So individualization is the key, and why it is important, because all patients are not same. They might have different eating patterns. Some are nil by mouth, some are eating liquid diet, some are on soft diets, different activities. Then there are drugs like steroid, total parental nutrition. Then there are insulin resistance related to the illness, and patient comorbidities like renal, liver dysfunction, and cardiac comorbidities. Then there are different diabetic phenotypes, which also differs. So if you see this slide, the yellow bar presents patients with diabetes and the red one without diabetes. And these were 3,200 patients who were admitted in surgical wards in patient with non-cardiac surgery. And it clearly shows that diabetic patient had more sepsis, more wound infections, more UTIs, more myocardial infarction and renal failure. So hypoglycemia, hyperglycemia and glycemic variability all lead to poor outcomes as compared to patient in non-diabetics. So even when you look at this slide, which is on the right side, this patient did not have diabetes, but stress hyperglycemia. And when you compare it with patient with diabetes, and this is a big data of 11,000 patients who were admitted in colorectal and bariatric surgery department, and patient with even stress hyperglycemia had more complications, that is wound infection, sepsis, again, all these complications were very high in patients with stress hyperglycemia. So hyperglycemia is a marker of severity of illness. So it should be taken care of even if it is a stress hyperglycemia. And as rightly said by previous speaker, you should check for HbA1c if it is not done in last 30 days. And if it is more than 6.5, it is overt diabetes which was not diagnosed. So what are the target levels? So target as given by ADA should be 100 to 180 in wards. And Endocrine Society says pre-meal blood glucose at 140 and random at 180. And all other guidelines have similar target glucose levels for patients admitted in wards. And as rightly said, that 80 to 110 causes more mortality as compared to 140 to 180. So more conservative approach is better for the patients. So what about the recommendation of insulin? How we arrived at this insulin regimen recommendations? So there were few studies which were the basis of recommendation of insulin, and what type of insulin, whether it is basal bolus or basal plus or with OADs, were differing because of the trials which we had. So this was one of the biggest trial, rabbit trial. On the left side, you can see those patients with basal bolus therapy and sliding scale were compared. The basal bolus has better glycemic control as compared to sliding scale. And if you see the rabbit surgery hospital complications in patients with basal bolus had better outcome as compared to sliding scale, and they had more sepsis, bacteremia, respiratory failure, acute kidney injury in patients who were on sliding scale. So these trials were the basis of recommendation of basal bolus therapy in hospitalized patients. Now the question will come in mind whether we should use a human and or analogs. So this shows a comparison between the analogs and NPH and regular insulin. So left side shows a comparison between datimir and aspart, and on the right side it shows the comparison between glargine glulysin versus NPH and regular. So if you see from the day of admission till the stay in the hospital, the glycemic control was comparable, and this was because that these trials are treat to target trial, and the whenever the sugar went up, the glucose insulin dosages were adjusted accordingly. And if you see, the glycemic control is comparable in both the charts. So whether you use a human or analogs, the glycemic control is comparable. However, when you look at that right side, hypoglycemia episodes were more in patients who were using NPH and regular, and that is makes sense because NPH has peaks. So now the question will come, how much of us will treat patients in the wards with pre-mixed insulin? Because lot of patients in India are treated with pre-mixed insulin in wards. So what is the comparison? Again, if you see day of admission till the stay in the hospital, when pre-mixed and basal bolus were compared, the glycemic control was comparable. Again, these are again treat to target trials. So the glucose went up, the doses went up, daily adjustment of doses was done. But you look at the right side, if you see 30-70, any time of the day, hypoglycemia is 64.1%. So if you ask me whether you will use premixed insulin in the wards, okay, you can use it, but be careful of hypoglycemia and keep the target little high around 180 to 200. So now next question comes, which basal insulin to be used? So glargine is most frequently used in our institute, and I use glargine. When you compare with the other three analogs, Levemir, glargine U300 and Degludec U100, there were lots of data presented over these comparison. I'll show you three slides. And if you can see all three slides, when you compare them with glargine U100, the glycemic control is similar. There is no difference in the glycemic control. And when you look at the hypoglycemic incidence, again, it is comparable, except glycine U300 versus U100. U300 has lesser severe hypoglycemia as compared to U100, but still it did not achieve the statistical significance. So if you summarize till now, what uh, regimen you will prefer? It is basal bolus, which is preferred over sliding scale insulin, and there is no difference among the basal analogs comparing the glycemic control as well as hypoglycemia episodes. So is it really good? Okay, there are limitations of basal bolus regimens. There is hypoglycemia risk. It is a complex regimen. There are multiple daily injections, and it might be a over treatment in many patients. Like a patient comes with a random blood glucose of 150 and HbA1c less than 7.5. Will you use the same regimen in those patients? No. So what are the alternatives for us in non-ICU setting? One of them is basal plus, where you use a basal dose in 0.2 to 0.25 unit per kg body weight and give a correction dose in rapid acting analog or a regular human insulin. Incretin agents can then be used. Yes, they can be used in combination with basal insulin. And what is the data regarding sliding scale insulin? So this is the guideline given by ADA. If patient is uncertain of oral intake, start basal dose at 0.2 to 0.25 unit per kg body weight and give correction rapid acting insulin as required. and adjust the basal as per the HGT charting or point of care testing. If the patient start taking adequate oral intake, then basal bolus therapy. Total daily dose may vary from 0.3 to 0.6 unit per kg per day depending on the sensitivity of the patient, and half basal, half bolus, and then you adjust as per the point of care testing. So how this basal plus came, because of this small trials where 370 patients were compared with basal plus and basal bolus therapy. And if you see medicine and surgical department, graph almost resemble each other, and there was a comparable glycemic control even with basal plus. And this was the basis of recommendation of basal plus in some patients. And you can always go on to basal bolus if the patient is started taking adequate oral intake. And one caveat is that you should reduce the total daily dose to 0.15 unit per kg body weight in those patients who have CKD and above 70 years of age to prevent hypoglycemia. So this was the data on continuous sliding scale insulin therapy. Almost 25,000 patients were compared. And when the patient comes with a glucose level of 140 to 180, sliding scale also gives you success because there is less hypoglycemia, less amount of insulin dose is required, and almost 80% achieved good glycemic control with sliding scale insulin therapy. However, as the glucose goes up from 180 to 250, only 16% could achieve the glycemic control which we targeted. So this is a classical example of our institute. If you can see, sliding scale therapy is not indicated for this type of patient. They give 6 unit 138, again 20 units 96, then no insulin was given, again 20 410. So this is how roller coaster ride goes on. So what about non-insulin agents? Are there any data regarding the same? I think Dr. Mathil is going to present, but I'll give you a few slides. So this was the largest trial, 80,000 patient, which was presented in ADA in 2023. And when you compare, glycemic control was not as good as basal insulin. However, hypoglycemia risk, mortality were lesser in the OAD group, and lactic acidosis was similar. So this was the emergency surgery, patient undergoing emergency abdominal surgery, and then they were compared those patients who were on insulin and oral agent. Definitely insulin patients were having better glycemic control, less wound infection. However, if you look at the cardiac arrest and complications overall, they were less in oral agents. So there is a lot of data. In Israel, almost 70% patient in wards are treated with oral agents, and in UK, 40% of patients. So what about metformin? Is it a safe option? If you select the patient judiciously without renal dysfunction and cardiac dysfunction, sepsis, hypoxemia, then you can definitely treat with a low dose of metformin or 3 times metformin and a correction dose of insulin. Correction doses are different from the sliding scale doses because they are small maneuvering dosages as compared to the sliding scale therapy. So these were on DPP-4 patients and surgical patients and in-hospital patient. And you can see with basal or with sitagliptin alone or with basal bolus when they were compared, they had comparable glycemic control. Again, sitagliptin and linagliptin trial. This was a DARE-19 trial with SGLT2 inhibitors, EMPA trial with SGLT2 inhibitor in the wards. However, you should be careful that 38% of DK cases were there in users of SGLT2 during admission. So patient prior to surgery, we should stop 3 days prior to the hospitalization for surgical intervention. What about GLP-1? GLP-1 also had comparable glycemic control with exenatide on lower rates of hypoglycemia in the exenatide groups. However, GI side effects of nausea, vomiting. So anesthetists are worried about aspiration and also it should not be used. How glucose monitoring schedules based on nutritional intake. So if patient is on IV insulin every half an hour to 2 hours, you can check. Patient who has nil by mouth 4 to 6 time readings, and then accordingly you can give rapid acting insulin. And patients who are eating well, at least 3 to 6 readings should be done and 3 MRBS to rule out any midnight hypoglycemia. So if I summarize, insulin in most of the patient with significant hyperglycemia, what are the caution? Hypoglycemia risk, CKD, poor intake should be taken care of. Metformin, stable patient can be taken. Type 1 diabetes, renal liver failure, hypoxia, sepsis, these patients should not be put on metformin. TZDs are not routinely recommended because it takes time for its action to start. DPP-4 inhibitor can be used in mild hyperglycemia. You can combine with insulin. However, caution is pancreatitis, severe hyperglycemia, and type 1 diabetes. SGLT2 inhibitors should be used in patients who are hospitalized with heart failure and once they are hemodynamically stable. because they reduce the incidence of rehospitalization of patients with heart failure. So treatment regimen will differ in different type of patients: low regimen complexity, high complexity, and those patients who are already on basal bolus. So if a patient comes with a sugar of 150, HbA1c less than 7.5, you can definitely keep them on SSIs as well, low dose of basal or basal plus, and with OADs. When patient is more than 2 anti-diabetic agent, more than 7.5 to 9, poor oral intake, then you can give basal insulin and correction dose. And basal bolus is preferred those patients who are already on basal bolus, they have come from the home on basal bolus itself, then you continue basal bolus and don't try to shift on other parameters. So this is what is individualization. A patient with a heart failure with 167 and A1C of 6.8, whereas other patient with a very high blood sugar of 311. So here oral or a basal plus can work, and in that patient you will require to put that patient on basal bolus and hold the oral agents. Now, whether we can use glucose monitoring technology in the hospital, closed loop. So when we go for rounds, we look at 3 or 6 readings which have been provided for the yesterday. And when you do the CGM, you get almost more than 100 or 200 readings in a day. And then you can compare with that. Advantage with CGM is that hypoglycemia detection, which is less than 70, 45% time it is masked. So hypoglycemia detection is much better achieved with CGMs. So question is, ASE says, should CGM can be used in patient who are hospitalized for non-critical illness? So recommendation 1.1 says that it can be used in non-critical illness who are at high risk of hypoglycemia. And we suggest the use of RT-CGM with confirmatory POCBG bedside monitoring, as Dr. Vimal had already told. So it is little cumbersome, but it can be used. And as the technology advances, more and more updates will come. So thank you. My take-home message would be that
Thank you, Dr.
use
Ashok.
insulin, basal bolus therapy in most of the patients, but you can definitely use basal plus with correction dosages, and it may not be appropriate for all patients, but we can segregate them and try to give them lesser number of injections if possible. Thank you.
Our next speaker is Dr. Mahendra Patel, who is a diabetologist from Thane, and he'll be speaking on perioperative glycemic management.
So good afternoon, everyone. I think so. My topic is much simpler than the other topics. It's basically perioperative glycemic management. It's basically ensuring optimal blood glucose control in the surgical patients when the patient is going to undergo any surgery. So basically, the overview is importance of glycemic control in the perioperative period. Why it matters? It impacts the hypoglycemia on the surgical outcomes, how the patients come out from the surgery. The perioperative glycemic management is crucial for minimizing the surgical complications. Hyperglycemia during surgery is associated with poor outcomes, and high blood glucose can increase the risk of infections, delay wound healing, and contribute to other complications. So, what is the basically the pathophysiology of hyperglycemia in surgery? Surgery induces a stress response that elevates hormones like cortisol and catecholamines, which leads to hyperglycemia. Surgery related stress and inflammation increases the insulin resistance, which complicates the glycemic control, and cytokines and hormones released during surgery contribute to higher blood glucose levels. So, risk of poor glycemic control. So, what are the risks associated when the sugar is not controlled during surgery? Is the hypoglycemic risk are basically the increased risk of SSIs, poor wound healing, and higher incidence of CV events because of high sugars before surgery. And the risk of poor glycemic control for hypoglycemic risks are basically when there is a high hypoglycemic chances, the increased risk of CV events is there. Confusion and neurological complications can occur, and potentially fatal outcome is also seen with hypoglycemia during surgery. So studies have shown a direct correlation between high perioperative glucose and the increased mortality. Also, patients with poor glycemic control often have longer hospital stays due to complications. So basically, what is pre-operative glycemic management? How do you are going to see your patients? First, you assess the patient, evaluate the baseline sugar levels and the HbA1c levels. Then you adjustment of the diabetic medications, like adjust insulin or the oral hypoglycemic agents. Try to control your sugars. Also, non-diabetic medication should be looked into that may affect the blood glucose levels during the surgery part. The guidelines for blood glucose levels during surgery are basically you should maintain your blood glucose levels between 80 to 180, and a target HbA1c of 7% is generally recommended for elective surgery. Planning for insulin therapy is basically adjust the insulin doses before surgery. Long-acting insulin may be reduced. A short-acting insulin may be withheld on the morning of surgery, depending on the time of the procedure. Otherwise, you can give insulin during surgery. Intraoperative glycemic management during the surgery part. Monitoring of sugar is important. You have to have a continuous or frequent blood glucose monitoring. Interventions, infusion protocols, and avoid dextrose containing fluids unless necessary. The target ranges aim for glucose levels between 140 to 180 during the surgery. And hypoglycemic management is basically very important. Have a protocol in place for treating hypoglycemia, which may include IV glucose or oral carbohydrate intake if the patient is conscious. The post-operative glycemic management is also important. You have to monitor the sugars frequently. Blood sugar checks should be checked every 2 to 4 hourly. Insulin therapy, adjust the insulin dosing based on the surgical recovery and the nutritional intake. And the complication prevention, emphasize infection control, wound care, and monitoring for signs of hypo or hypoglycemia. So what are the special considerations for diabetic patients? In type 1 patients, we have to be careful because patients might go into ketoacidosis. Type 2 diabetic patients may require temporary insulin therapy during the surgery, and medication adjustment should be done. But you have to be careful while using metformin or sulfonylureas, where there is a risk of hypoglycemia, and other agents like SGLT2, which there is the risk of euglycemic ketoacidosis. In emergency surgeries, manage hypoglycemia aggressively with insulin infusions, aiming for the same target glucose range of 140 to 180 during the period of surgery. So guidelines and protocols are already been explained. Basically, current guidelines and recommendations that you can follow your hospital protocols and standard operating procedures. Even ADA or AC guidelines can be followed. And evolving evidence is that emergency research on tight versus moderate glycemic control is still in view. Not 100% sure, but I think so. Moderate glycemic control is good during surgery because of the risk of hypoglycemia. So this is basically a case where managing perioperative glycemia in a patient with poorly controlled diabetes. Patient is Mr. XYZ, 58 years old, type 2 diabetes since 15 years, having hypertension and hyperlipidemia. His current medications are metformin, glimepiride, telmisartan, and atorvastatin. HbA1c is 9.2%, BMI is 32%, and the procedure which the patient has to undergo is elective total knee replacement surgery. So it's a major surgery. So the pre-operative consideration is basically the glycemic control. HbA1c is high, so it indicates a poor glycemic control. Pre-operative optimization, so consider starting a basal bolus insulin regimen in this patient. Aim for pre-operative blood glucose of 140 to 180 milligrams per deciliter. Discontinue oral hypoglycemic agents 24 to 48 hours before surgery. Pre-operative considerations, what is the risk assessment? You can say that cardiovascular risk, consider ECG in this patient because otherwise you might require a cardiologist. Renal function should be assessed because that patient is 15 years of diabetes. He can have a diabetes kidney function dysfunction. Also, pre-operative education has to be given to the patients. The instructions are like importance of glucose monitoring, adherence to the insulin regimen, and recognizing signs of hypoglycemia. Intraoperative management, the glycemic targets should be between 140 to 180 to reduce the complications. IV insulin infusion or subcutaneous short-acting insulin can be given, and frequent blood glucose monitoring should be done. In the fluid management, balanced crystalloid should be given. Use lactated linger to avoid hyperchloric acidosis. and avoid dextrose containing solutions to prevent hyperglycemia. The post-operative management for this patient will be immediate control, sugar monitoring every 2 to 4 hourly, insulin adjustment based on glucose readings, resume regular regimen post stabilization of the patient, and also preventing complications. You have to prevent hypoglycemia, so the insulin should be titrated carefully. And infection prevention, administer the prophylactic antibiotics and emphasize wound care and monitor for infections. How you plan to discharge this patient? Basically, that is a discharge planning. Patient education should be important, emphasize importance of glycemic control, medication adherence, and lifestyle modifications. And follow-up can be, you should ask the patient to have early follow-up in these patients because the major surgery and the sugar insulin we have started in this patient. So basically the key points are poorly controlled diabetes increases the perioperative risk. Multidisciplinary approach is essential. Glycemic control is critical for reducing complications and improving recovery. In summary, optimizing glycemic control in perioperative care is crucial for patients' outcomes, especially in those with poorly controlled sugars. So thank you.
Thank you, Dr. Patel.
Now our next speaker is Dr. Firdaus Sheikh. She'll be taking us on after discharge. Do we stop insulin or continue? Over to you.
One done.
ब्राइटनेस थोड़ा बढ़ा देना. Good evening, everyone. At the outset, I would like to thank Dr. Manoj Chawla sir and Dr. Purvi ma'am for giving me this opportunity, and thank you all for being here. So all the speakers before me did an excellent job of making my talk very easy. And as we know, in hospital management and discharging the patient on insulin, should we stop? Yes or no? It as Dr. Akshay Kothari sir said, everything has to be individualized. There is no one blanket fits all. So my talk would be on the focus on the decision making process regarding the continuation or discontinuation of insulin therapy for patients being discharged from the hospital, and we will explore the factors that influence this decision, such as patient specific characteristics, glycemic control status, and the presence of comorbidities, and the latest guidelines. What do they say? So glycemic status at discharge is of very clinical importance. Critical decision point. This is the decision to continue or stop insulin at discharge is crucial because it directly affects the patient safety, glycemic control, and the risk of both hyperglycemia and hypoglycemia after discharge. We have to balance the risk versus the benefit. All clinicians must balance the benefits of maintaining glycemic control against the risks associated with insulin use, particularly the potential for hypoglycemia, which can lead to adverse events and rehospitalization. And it should be a very patient centered approach, emphasizing a personalized approach. We need to consider each patient's unique situation, such as the elderly, those who need extra care, including their ability to safely manage insulin therapy and access to outpatient support. So coming to the guidelines, the ADA, they recommend in type 1 diabetic to continue insulin therapy. All patients with type 1 diabetes should continue insulin therapy at discharge. This is because they are insulin dependent and are high risk for diabetic ketoacidosis if insulin is stopped. Insulin regimen, patients should be discharged with a basal bolus regimen, as Dr. Akshay Kothari mentioned, and it should closely match their inpatient dosing. For type 2 diabetic patient, it should be a very individualized decision. The decision to continue or stop insulin at discharge should be based on the patient's current glycemic control, their HbA1c levels, and the overall clinical stability. Whether to continue insulin, the recommendation for patients with significant hyperglycemia, HbA1c of more than 9%, or those requiring higher doses of insulin in the hospital, it is advisable that they continue insulin post discharge also. Discontinuing or reducing insulin, consider stopping or reducing insulin if glycemic control improves within the hospital stay, and then we can manage them with non insulin therapy. Coming to gestational diabetes, continue insulin therapy in patients with gestational diabetes who require insulin during pregnancy, as hyperglycemia postpartum could persist. Of course, we need to check their glycemic status 4 to 6 weeks postpartum, and postpartum monitoring is of extreme crucial importance. Coming to the guidelines on insulin titration, monitoring, and patient education for discharge, insulin titration adjusts doses based on inpatient glucose monitoring trends and any changes in diet and activity, because we know during hospitalization, diet and activity all goes for a toss, and when they go back home, everything maybe would get better or would not get better, or medications post discharge, and provide specific instructions for dose adjustment to patients and the caregivers. Monitoring, frequent glucose monitoring is required. Recommend frequent glucose monitoring post discharge, particularly in the first 1 to 2 weeks. And follow up is very crucial, 1 to 2 weeks of discharge, to reassess insulin needs and adjust therapy if needed. Patient education, again, of very importance. Educate patients on insulin administration technique, recognizing and managing symptoms of hypoglycemia and hyperglycemia, and adjusting insulin in response to changes in diet and activity. Now, coming to the guidelines, the American Association of Clinical Endocrinologists, the differences and the similarities compared to ADA, with similarities, emphasis on individualization. Both ACE and Endocrine Society guidelines emphasize individualized treatment plan based on specific patient factors such as the type of diabetes, glycemic control, and comorbidities. And insulin continuation for type 1 diabetic patient, there is a strong consensus that insulin therapy should not be discontinued for type 1 diabetic patients at discharge. The differences with ACE guidelines are ACE often provides more aggressive targets for glycemic control and recommend tighter glucose ranges, which may influence the decision to continue insulin therapy even in patients in type 2 diabetic and with gestational diabetes. With Endocrine Society, they may offer more specific recommendation regarding insulin adjustment for special population, example those with renal impairment and the elderly. Coming to the principles of discharge, for people with diabetes, there are multiple factors which we need to take under consideration. Transition of care, including poor communication, patient education, inappropriate follow up, and all clinical complexities. So, there are multiple factors which should be taken under consideration. Discharge planning should therefore recognize the complex interplay between physical, social, and most importantly, psychological factors, as well as educational needs and external influencing factors. So, factors which affect the dosing of insulin discharge are diet, activity, medications, and psychological stress. So, the initial discharge assessment, this is the assessment tool and referral criteria by the diabetes specialist team, which they should make. So, always refer patients. Those who require surgery, those with diabetic ketoacidosis, those who are newly diagnosed type 1 diabetic, newly diagnosed type 2 diabetic, those who require intravenous insulin infusion with glucose outside of limits, meaning very high sugar levels, previous problems with in hospitalization, intravenous insulin infusion for over 48 hours, impaired consciousness, unable to self manage, requiring parenteral or enteral nutrition, foot ulceration, sepsis, vomiting. And we may or may not require the diabetes specialist team to see patients who have type 2 diabetes, stress hyperglycemia, and those who are on steroid therapy, as most of these conditions they resolve when we stop all of these medications, and rarely refer patients who have transient hyperglycemia, and those who are well controlled with their diabetes levels. So these are the principles of discharge planning components. The discharge needs should be assessed within 24 hours of admission. Discharge should be referred to the discharge coordinator as soon as possible. Care planning and goal setting should involve the person with diabetes. Sharing of key information throughout the inpatient stay and again on discharge. Focus should be on management and of medicines. The discharge plan should be reviewed daily and twice daily to meet and recite criteria. Provide all the necessary equipments and education related to diabetes care. Share the expected treatment pathway post discharge and any investigation results which are pending with action to be taken post discharge. Now, areas to consider during discharge treatment, again, the type of diabetes, the degree of glycemic control, current glycemic stability, diabetes management, diabetes equipments, diabetes complications, ability to communicate, nutritional status of the patient, and the educational need, the social factors, socioeconomic factors, language barriers, mental capacity if the patient has dementia, Alzheimer's, or any other mental illness, educational potential if the patient has vision problem, hearing problem, cognitive disability, social support if the patient requires a caregiver, community support, medications post discharge, and homelessness. This is a major consideration, especially in our country and again in the United States, where uh, uh, insulin therapy is unfortunately very expensive over there. Coming to the physical part, normal functional level prior to admission, physical self-care limitations, example blindness, stroke, amputation, functional level ability to self-care, and consideration of age, presence of any symptoms, presence of comorbidities, life expectancy, prognosis, end of life care, physical capacity to comply with treatment, and mobility. So these are the discharge checklists for people taking insulin. So insulin therapy, a starter pack of new, if new to insulin, standard pen injection needles, safety pen injection needle samples, lancets for fingerprint pricking, glucose meters, glucose strips. All patients with type 1 diabetes and some patients with type 2 diabetes who have a history of DKA should be given a ketone meter also. Sharp boxes, discharge letter, referral to district nurses, contact details of diabetes team and the hospital team and those who are in charge of the patient, and follow up if required. So, the clinical scenarios to assist with discharge planning on those who are taking insulin. For example, if a person is unable to self administer insulin safely, or like for example, if they have cognitive impairment, learning disability, dementia, if they have a risk of self harming, basically psychological factors, mental health care issues, have visual impairment or other issues, then we need to take all of these factors under consideration. HbA1c test at the time of discharge is of very critical importance. So, interpretation of A1C test at discharge. The A1C test result is very valuable in determining the most appropriate treatment strategy at discharge. Patient with a history of diabetes with acceptable control and A1C is in the goal range can probably be discharged on their pre-hospitalized medications or on insulin regimen, and patients with suboptimal control should have intensification of therapy either by addition or increase in oral agents, addition of basal insulin, or a complex insulin regimen. So, the three pillars of a successful discharge planning are medications, glucose monitoring, and outpatient education and follow ups. So, coming to medication, basal insulin recommendations are, if needed, start once daily basal insulin or twice daily premix insulin, as Dr. Akshay Kothari sir mentioned. A combination of metformin, SGLT2 inhibitors, a GLP-1 receptor agonist, can likely decrease A1C by more than 3%. Therefore, if a patient's HbA1c is 3% higher than target, adding insulin may be necessary, especially if the patient requires considerable basal insulin during the hospital stay. Coming to glucose monitoring, recommendations are, consider prescribing a CGM system to patients with high A1C values or those who are obese or who are taking medications known to cause hypoglycemia. By having continuous real-time data, patients can better understand how other lifestyle choices such as food and exercise can affect their glycemic control, which in turn may motivate patients to make healthier choices. Outpatient education and follow-up is very important. So the barriers to I'll just come to the benefits of continuation of insulin after discharge. Benefits are there is a risk of hypoglycemia, of course, which can be decreased if we explain to the patients. Lower risk of all cause hospital readmission, less diabetes related readmission, low all cause emergency department visits, and improved survival. Now, the situations which favor discontinuation of insulin at discharge are patients with transient hyperglycemia, stress induced hyperglycemia, hyperglycemia that occurs due to acute stress such as surgery, trauma, infection, or severe illness. It is not required to continue insulin post discharge. Those who have as I mentioned, those who are taking steroids, that causes temporary elevations in blood glucose level. In such patients, the steroid doses, as we taper it down, then the insulin doses also can be tapered down and they can be discontinued. Close monitoring of blood glucose level is necessary even though the patient has transient hyperglycemia. So I'll just come to the key takeaways. So, individualized patient care is very important. Tailoring insulin therapy based on unique patient needs, importance of patient centered decisions, patient assessment, assess HbA1c levels, the type of diabetes, the history, the comorbid conditions. This is all important in the decision making framework. Benefits and risk, discontinuation, reducing the risk of hypoglycemia, simplifies regimen. Continuing insulin ensures control and it prevents complication. There is obviously a lot of current research which is going on, and most important is the patient care should be individualized and patient centered. Thank you.
Thank you, Dr. Firdaus.
So our next speaker of the day is Dr. C. Muralidharan, who is a diabetologist at Dindigul, and he will be speaking on common errors in insulin injection technique.
file कर दे
15 minutes and
काढता ना तुम्ही
कोणता आहे
15
सी मुरली
Good evening, friends. It gives me immense pleasure to be with you. All the speakers, they talked about the insulin, ICU setup, non-ICU setup, discharge, so many things. Now we want to know what are the mistakes committed by our patients during the day-to-day clinical practice. This is the most important thing. kudos to the Dr. Manoj, Purvi, and the entire team for inviting me to give a talk and for the wonderful conference. Lord Ganesha bless the conference, all success. Common mistakes in insulin injection technique. So most of the patients I told you, whether they are taking vial syringe users or pen users, they commit lot of mistakes in the during insulin injection, which leads to adverse events, including hypoglycemia, uncontrolled HbA1c, glucose variability, lot of things. So we have to overcome all these things. There are a lot of unique mistakes our patient they commit. More than 25 mistakes I identified. There are still more, but time permits I can cover. The first mistake, a common mistake, is injecting insulin into the muscle. That should be avoided because subcutaneous injection insulin is needed for the consistent and steady, stable absorption to give the good results. But injection into the muscle leads to accelerated absorption leading to hypoglycemia, so it should be avoided. And in the past, we were using 6 needle for the children and 8 needle for the adult. Long enough, they increase the risk of IM. So we should avoid. The recent publication, they show 4 needle for pens and 6 needle for syringes. They are safe, effective, and less painful. They are the first line choice in all the categories. Second mistake, common mistake, is this is for the syringe users using the whole hand while lifting the skin fold for injection. So actually for the insulin pen users, we don't need. For the syringe users, we need to have skin fold lifting up. When you do it using the whole hand, a risk of including the muscle, so intramuscular injection should avoid. You have to use the thumb and the index finger for using it. Third mistake is releasing the skin fold while the needle is still inside the skin. So you have to release the skin fold only after removing the needle from the skin to ensure the injection is to be delivered into the subcutaneous fat. And injecting into the, not injecting into the clean sites. We have to inject into the clean site using the clean hands. But you will agree with me, most of the nursing homes, our staff members, they don't even wash their hands. Simply they give it. We have to educate our staff members. You have to use alcohol soap. Do not use soap-based detergents or chlorxylenol, cetrimide, all those things to clean before the injection. And for the insulin pen users, releasing the thumb button while needle is still inside the skin, you have to keep the pressure on it once the thumb button is pushed inside until the needle is completely withdrawn from the body. The button is released while the needle is inside the skin. What will happen? The body fluid will be aspirated and it may contaminate. And the same pen injections, you have to count 10 seconds. But most of the places, we are not counting 10 seconds or more while injecting with the pens. What will happen? You have to give sufficient time for the injected insulin to spread out through the tissue planes and cause the tissue to expand. There is mainly it is very important, and this is needed to prevent the medication leakage. And most of the cloudy insulins like NPH insulin and premixed insulins, we have to resuspend, we have to mix it. But most of the places our staff members are not doing it. We have to educate it. Inadequate resuspension can lead to varying concentration, which will lead to unpredictable clinical outcomes. And vigorous shaking should be avoided. Otherwise, air bubbles will appear and will prevent the flow, the dosage inaccuracy. You have to roll the insulin vials or pens between the two palms, or tipping the pens is essential for the insulin crystals to uniformly mix in the suspension. And injecting into the same site again and again to be avoided. Poor site rotation to be avoided. Injecting insulin into the forearms, calf muscles, all those things to be avoided. Repeated injection to the same site leads to abscess formation and scarring. And patient we have to advise injection sites abdomen, upper thigh, buttock, upper arm. And for the self injection, we should advise the patient. This very ideal set is abdomen and thigh. They can easily inject, they can visualize. So advise the patient to divide the injection site into 4 quadrants, 1 quadrant per week, and rotating quadrant to quadrant in a consistent pattern will give the correct site rotation. Injecting into the same site leading to inflammation, bruises, abscess formation, and painful and LH formation. And we have to educate the patients and our staff members and the family members regarding the inspection of the injection site. And doctors also, we have to ensure sit with the patients at least once in 3 months. We have to examine the site, advise the patient to examine the site before each injection. Injecting into the LH site, what will happen? Injecting into LH site, variable absorption, unpredictable outcomes, hypoglycemia, glucose variability, and uncontrolled HbA1c should be avoided. And husband and wife sharing the insulin syringe or pens, needles. So whether they are husband and wife, lovers, boyfriend, girlfriend, whoever may be, it should not be shared because it is meant for single patient use and needle should not be reused. And I told you lipohypertrophy, now lipoatrophy. Injecting into the same site, again and again a depression is formed. So that is lipoatrophy, clinically visible cutaneous depression and palpable atrophy in the subcutaneous fat tissue at the site of injection. Nowadays, with the advancement of the purified insulins and analog insulins, it is uncommon. Dripping from the needle while it is on the pen. So most of the patient they tell, what sir, it is quite costly. Every time when I inject, some 4-5 drops are wasting. How can I afford to do all these things? So we have to educate. When there is a dripping, you have to look, which is improper seal between the needle and the cartridge. We have to ensure it, and we have to tell the patient how to examine it. And also, if the plunger is not held down correctly, then there is a risk of dripping from the needle. And also, if the needle is taken out of the skin too soon, then this will happen. All these things should be avoided. And reflex or backflow out of the injection site is also common due to the needle is taken out too soon. And not spending time with the patients to educate on insulin. One study says that across India, most of the doctors, they spend only 2 to 3 minutes per patient. This is a scenario. But for the diabetic patient, minimum we have to spend some 10 to 15 minutes. Otherwise, we can't justify. At least we have to educate our staff members, train our educators, dietitians, and family members. They have to spend time with the patient. Education is a mantra if you want to achieve the good glycemic control with the insulin without the risk of hypoglycemia. And storing insulin in the freezer. So insulin should be stored in the ideal temperature of 2 to 8 degrees Celsius. That should be in the door of the fridge. Some of the patients, they are not properly educated. They store it in the freezer. Once it is frozen, then no point in it. The potency is lost. We have to educate. That too, the insulin vials or pens are not opened. New things should be stored. Once you use it, it should not be, according to FITR guidelines, you should not be stored in the fridge. You have to take it out, keep it in the 15 to 30 degrees Celsius ambient temperature. There should be followed up to the 30 days or expiration date. The reuse of needle is very common among the Indian patients because of the cost. Pen needles are around 13 to 14 rupees. So every time when the patient is taking some basal bolus insulin as suggested by this gentleman, 3 to 4 times he have to change the needle. Means for the needle alone he has to spend some 50 to 60 rupees per day. In our setup, it is impossible. So what we advise our patient is, off the record we are telling that one needle can be used for 3 3 times. We advise the patient 3 times. And but our patient, what they are under the impression that unless they get the pain, they don't change the needles. Some patients are using the same needle for 2 to 3 months at a stretch. They are injecting into the LH side. There is no pain at all. They continue to do it. LH side, remember, there will not be any pain if you prick it. So the patient prefer to give in the same side. So we have to see the pen fills, vials, syringes, needles. We have to check, or we have to assign our staff to verify it. Unless otherwise, patient will end up in hypoglycemia. The reuse of needles, lot of problems are there. See the new cannula multiple times. The damage to the reused syringe needles is likely even greater, because syringe needle, before each and every prick, the needle has to pass through the rubber stopper of the vial. Another prick is there, so painful. And the residual insulin inside the needle crystallize, block the flow of the insulin, and dosage inaccuracy will be there. So reuse of the needles, pain, bleeding, bruising, contamination, infection, dosage inaccuracy, sometimes breaking up the needle, lodging under the skin, and lipohypertrophy. So applying alcohol on the needle before giving injection. Some of the cinemas movies, they show that they apply the alcohol on the needle. Should be avoided. Applying alcohol on the needle will impair the lubrication and very painful. We should not do it. And using the insulin immediately after removing from the fridge. So it is very cold. You have to allow the vials and the pens to come to the normal temperature. Then only you have to give. Otherwise, cryodrama will be there. You have to avoid. And injecting on the wet surface, which is cleaned by alcohol. Yes, you can clean it by alcohol, but you have to allow time to dry it. Then only you have to give the injection. Otherwise, there will be irritation. So you should not use it on the wet surface. And injection through clothing. This is very common practice even in the villages, in the town. They inject through their jeans pant and blouse, all those things. A lot of things are there. Contamination. You can't visualize the site, and you can't pinch up the skin fold for the this syringe use, all those things. And sometimes the clothing fibers may enter inside and they irritate the skin. So needle become unsterile. So you have to avoid all these things. And incorrect, missed priming of the device. So priming of the device is very, very important. You have to tell the patient that. The patient used to say, "What, sir, you are telling the prime, I lose some 2 to 3 drops." No other go. You have to tell. Otherwise, the dosage inaccuracy will be there. We can't expect the glycemic control. And instead of depressing the injection button, they dial back on the dosage knob, believing that this deliver the insulin. We have to tell the patient this is wrong. So all these things we have to sit with the patient, educate the patient. Otherwise, patient will not follow. What usually we do in the busy practice, the BP, the sugar is uncontrolled. We tend to increase the dose of the insulin instead of seeing all these things. And they precipitated insulin, lumpy insulin, frustrated insulin. All these insulin should be this type of insulin. You have to identify and you have to throw it away. Patients should not use all these insulin. Otherwise, they will end up in all sort of problems. And mismatching the insulin syringe and vials. In India, India is the only country where we use 40 unit per ml vial, 100 unit per ml we are using. In the Western countries, they use only 100 IU. Because in India, we are using both. We have to tell the patient, this is 40 unit vial, 40 unit syringe, 100 unit vial, 100 IU syringe. And we have to sit with the patient. See, this is red in color, this is orange in color, this is red marking, this is black markings. Everything we have to teach, not only the patient, but also patient attenders. Otherwise, patient land up in either unexplained hyperglycemia or acute hypoglycemia. We have to, 2 more minutes, madam. Okay. So, and also one of the common practice in most of the places in our place, drawing the insulin using the syringe from the cartridge. They get the cartridge, they don't buy the pens. So nowadays, most of the pharma companies are giving free pens. So we have to pass on the benefit to the people. This is a free pen, 700 rupees, company is giving free, you use it. Sometimes what they do is buying the pen, spending the money, they don't do it, and use the syringe, use the cartridge, drawing the insulin from the cartridge. This is a worst bad practice. Using the 40 unit syringe with the 100 unit cartridges, problem. So we have to educate. And using the cracked insulin cartridge. One patient using the good insulin, good company insulin, basal insulin, up to 30-40 units per day, sugar is not under control. 250, 350 going up and up and up. So then we examined, we found out that there was a crack in the cartridge. Whenever he gave the insulin was leaking away. That was a problem. So you have to spend time with the patient. Otherwise, it is a main problem. Yes, another 10 slides, but I don't want to go through it. Only one important thing is there is an association between the cold injection, cryotrauma, with the development of lipohypertrophy. So there is one important thing. In elderly population, type 2 diabetic population, unexplained hypoglycemia, you have to examine lipohypertrophy. That is the main problem. When you examine the lipohypertrophy, the dose will come down. The patient will not go in for hypoglycemia. Okay, thank you very much for the patient listening.
Very well said, sir. This is very important rather than managing sugars. The important technique, how to use the correct way of technique, it is very important because these are the common mistakes I am sure each of us would be facing. So teaching is very important.
Thank you. Pardon? Yeah, yeah. And there are a lot more mistakes. The time is very short. Only one thing. Last slide. So it is our pleasure to invite you on behalf of Tamil Nadu RSSDA chapter. Our treasurer Dr. Balaji is here. I am the secretary. So we use this opportunity. Last slide. So we invite you for our track 2024 happening in Chennai. Yeah, 28-29 September. So it is our invitation to you, and national conference November 14, November 17, and one more thing, March 2025, March 1st and 2nd, 2025, our Tamil Nadu chapter is conducting the research retreat in Madurai. So we extend our invitation to all of you. Please accept this invitation. Thank you very much.
Thank you, sir. Now the last speaker.
इसमें सेव किया है
डॉक्टर विनोद ना
हाँ हाँ नहीं इसमें नहीं है वो कहाँ तो सेव किया उसने उसको Thank you so much, and thank you, Chairperson, and thank you, the DRS team. So I'll be speaking on, this is the last session of our workshop on OHAs, and so you can realize what is the importance of OHA in hospitalized patients. So I'm coming in last, and so basically, when we talk of oral hypoglycemic agents,
okay, in a hospitalized patient. So we know that hyperglycemia is a concern. We know the importance of having a good glycemic control because we have ample evidences, ample studies which have shown that if we maintain a good glycemic control during in hospitalized patients, what it does, it reduces morbidity, it reduces mortality, it reduces the days of hospitalization. A lot of benefits for the patient. And hyperglycemia is it's a continuous ongoing challenge. So when a patient gets admitted, a diabetic patient gets admitted in hospital, the usual protocol is what basically we stop all the OADs and start with insulin. That is what is followed. And you can say that OADs has got a very limited number of patients only we continue with OADs. So does the OADs have a role in any in a patient who has been hospitalized? So the decision to discontinue on oral diabetic medications, it's a very complex one, and it depends on a lot of factors such as the patient's clinical condition, the reason why the patient has been admitted, has clear vital his parameters, his oral intake status, the other drugs which are going on. A lot of things are going on for the patients. And the reason why the OADs are interrupted or modified, because of the acute illness of the patient. So there are a lot of things which are happening when a patient is acutely ill. The patient may be may be having hypotension, may have dehydrations, and these are basically, these are factors which can lead to development of various complications, acidosis or lactic acidosis for the patient. So the nature of the illness is important. Then the fasting or the NPO status, whether the patient is fasting, patient has been advised to remain nil by mouth because he's going for surgery. So again, that would be a reason why we stop or interrupt the OADs. Yes, presence of renal hepatic impairment. So because most of the OADs, they are metabolized by the kidneys and liver, and when these are impaired because of any reason, the half-life of the molecules can be affected, again leading to prolonged action, hypoglycemia, etc. of the patient. And then a lot of new drugs introduced to the patient, again leading to a lot of drug interactions about which we are concerned of. So what are the challenges and consideration basically in an hospitalized patient? It's the absorption of the molecule and its efficacy in hospitalized patient, risk of hypoglycemia, especially with certain OADs, oral hypoglycemic agents like the sulfonylureas, drug interactions. And then the concern becomes about monitoring and the dosing adjustments because the PKPD of the molecules get altered and adjusting the dose becomes quite difficult. Now, if you look into the recommendation, the older recommendations prior to 2012, so basically the ADA, the Endocrine Society, prior to 2012, what they have recommended is against inpatient use of all OADs and non insulin injectable medications due to safety and efficacy concern. But then we need to realize that when these recommendations were done, the molecules which we had was basically metformin, SUs, and the TZDs, and these molecules did not have good data supporting or any benefits of this using these molecules in hospitalized patients. But then things have changed. We have got newer classes of OHAs, the GLP-1 analogs, the D4 inhibitors and the AGL2 inhibitors, and all of these molecules have shown very promising, very encouraging results on the safety and efficacy of these therapies as compared to basal bolus regimes for managing diabetes in hospitalized patients with type 2 diabetes. So now let us look into the molecules one by one. And metformin, we start with metformin. So metformin is the first line therapy for type 2 diabetes in the outpatient setting. And the biggest concern for metformin is basically lactic acidosis. But then if you look into studies, I mean, if you look into multiple cohort studies, meta-analysis, they actually have not reported any increased risk of lactic acidosis. In fact, there's a Cochrane review, which have found no cases of fatal or non-fatal lactic acidosis in around 59,000 patient years of metformin use. And I'm quite sure that at the time, even in my 20 years of practice, I've not seen a single case of metformin-induced lactic acidosis. So in clinical stable patients, there is no good evidence to support routinely stopping metformin at hospital admissions. And then there are advantages of metformin is that, that it does not cause hypoglycemia, But still, there is a theoretical risk of lactic acidosis, which increases as the renal function curve goes down. So when the EGFR gets starts getting lowered, you need to do a dose modification. So between 30 and 45, you do modify the dose, and less than 30, you stop metformin completely. Then some small studies, showing benefits of metformin. This is a study done in stroke patients, so around 355 stroke patients with type 2 diabetes without severe renal impairment or pre-stroke impairment of activities of daily living. And in these patients, pre-treatment with metformin was independently associated with an improved neurological symptoms. The administration of metformin prior to stroke onset, it was associated with a reduced neurological severity and improved acute phase outcomes. A small study, you can say. And then metformin and the use of contrast media. So we diabetic patients undergoing any contrast media induced procedure, there's an increased risk of nephropathy, thereby affecting the renal function. So in any patients with type 2 diabetes undergoing any contrast media procedure, we preferably advise them to stop it prior to the procedure, and it's usually restarted 48 hours after the procedure if the renal functions remain stable. So important points to note: metformin should be avoided in critical ill patients because there is an increase because of other factors. Acutely ill, dehydration, heart failure, etc., can increase the risk of metabolic acidosis. And then patients with severe liver renal impairment and patients with heart failure. So in absence of clear evidence, physicians should carefully assess the risk and benefits in individual patients. Now, SU sulfonylureas, so we talk about the third generation sulfonylureas, glimepiride, glyclazide, but as with any SUs, the risk is always of hypoglycemia. So mostly these drugs are often discontinued because of the risk of hypoglycemia. And there's a study which showed that at least almost 19% of SU treated patients experience at least one risk of hypoglycemia in the hospital. And the predictors for hypoglycemia was age more than 65 years, concurrent treatment with insulin, and EGFR less than 30. So because of the substantial risk of hypoglycemia and the unpredictable nature of the nutritional intake in hospitalized patients, SUs should be used in these patients. Only the doses are held when the days of nutritional intake is decreased. And then some, again, some small studies of some benefits of SUs in hospitalized patients. So this is from a US hospital where some studies have indicated that SU drugs may confer protection against cerebral swelling and hemorrhagic transformation in severe acute hemorrhagic stroke. So the clinical use of SU drugs have shown to reduce the infarct size, decrease mortality rate, and improve functional outcomes in settings of an acute cerebral ischemia. Now, TZ again, this is something which has not been much studied in an inpatient setting, but still good proportion of patients, about 7 to 11% of the patients, who are treated with anti-hyperglycemic agents, they receive TZDs. The concerns, as we know that the onset of action is quite late. It takes at least 3 weeks of pioglitazone or any glitazone therapy to show its action. So any new initiation in hospitalized patients is of no use. Then the concern with TZDs is that of fluid retention and weight gain, especially in patients who are at a risk of fluid overload, renally compromised patients with a risk of heart failure. So in these patients, they are not recommended. The advantage is with TZD is basically the less risk of hypoglycemia since it's an insulin sensitizer. Then some observational study has reported a protective effect on myocardial ischemia reperfusion injury. So this is a study in diabetic patients with ST elevation MI, where pre-treatment with pioglitazone resulted in a better myocardial reperfusion, which was described by a lesser reperfusion injury, as defined by absence of reperfusion arrhythmias, better improvement of ejection fraction, and lower peak creatinine levels. And then we have the IRIS study. Basically, this is a very landmark study where patients with insulin resistance who had a recent history of ischemic stroke or TIA, where it was seen that exposure to pioglitazone was associated with a lower risk of stroke or myocardial infarction as compared to placebo. So good benefits in patients with TI and stroke is seen with TZDs. Now, D4 inhibitors, many of the slides have been discussed by Dr. Akshay. So where here we have some studies with sita and linagliptin. So this is a study with sitagliptin. This was a trial with 90 patients who were randomized to sitagliptin alone, sitagliptin plus basal insulin, or basal bolus insulin. And then again, you can see that the result was that no difference was observed in the primary outcome of mean daily blood glucose between sitagliptin plus basal and basal bolus. So basically, it suggested that sitagliptin can be, was effective in patients with type 2 diabetes with mild to moderate hypoglycemia, not in the higher range. So the same study sub-analysis showed that the patient with the randomization blood glucose more than 180 milligram per deciliter treated with sitagliptin, they tend to have a slightly higher mean daily blood glucose. So mean monotherapy with a D4 may not be effective for patients with moderate to severe hypoglycemia. And in the study with linagliptin compared with basal bolus insulin regime in general surgery patients with type 2 diabetes. This was again an open label multi-center RCT with the type 2 diabetic patients undergoing non-cardiac surgery with admission blood glucose between 140 and 400 who are categorized with patients with diet oral agents and linagliptin with basal compared to basal bolus. Again, the endpoint was basically change in the mean blood glucose levels. Again, this study, you can see that in patients with randomization blood glucose less than 200, the mean blood glucose was similar with the linagliptin as compared to the basal bolus. However, patients whose mean randomization blood glucose was more than 200, here linagliptin group had a higher blood glucose compared with basal bolus. So similar to what we had seen in the sitagliptin study, if the blood glucose is higher, there the D4 alone was not found to be much effective. But then advantages was lesser hypoglycemia, the lesser requirement of insulin doses was seen with linagliptin arm. So you can say that treatment with oral D4 inhibitor alone or in combination with the basal insulin is safe, effective, and can offer an alternative to basal bolus therapy in most patients with diabetes, especially in patients who have got mean blood glucose of less than 200 milligram per deciliter. GLP receptor analogs, very less studies. So when we talk of an oral therapy, we only have semaglutide now. So no study as such of sema in inpatient hospital. But then we have very good data with the GLP-1 analogs, the injectable analogs, where what we have seen that the infusion of endogenous GLP-1 and GLP-1 receptor agonist may lead to an improved endothelial function, reduced infarct size following MI, and increase in left ventricular function in patients with heart failure and patients following a CABG. And then we also have the CVOT where it has shown that the beneficial effects can be a class effect for GLP-1 analogs. The concern basically with any GLP-1 therapy is the GI side effects. So that becomes a concern, especially in patients who are admitted with who are acutely ill, who has got a GI complaints, who's been admitted for gastrointestinal illness, whose oral intake is compromised. So that can be exacerbated with this GLP-1 therapy. So basically the surgical guidelines, the anesthetic guidelines, they have recommended discontinuing the GLP-1 receptor therapy at least a week before surgery to mitigate the risk of aspiration. So coming to the last portion, that the AGL2 inhibitors. So if you look into the current guidelines from the Endocrine Society and the EDA, they recommend to stop giving SGLT2 inhibitors to acutely hospitalized patients due to the risk of euglycemic decay. And also the surgical societies, they recommend holding SGLT2 inhibitors at least 3 days before planned procedures, and recommends testing for blood ketones in asymptomatic perioperative patients. So basically, SGLT2 inhibitors, the concern is always of euglycemic decay. Therefore, if we are continuing, if the physicians are prescribing SGLT2 inhibitors, they should be looking into the patient's risk of developing any euglycemic decay, like previous episodes of decay, possible type 1, etc. Patients requiring insulin. So the clinicians has to have a more nuanced approach in managing these medications, but certain conditions may seem to be consistently related to poor outcomes, including sepsis, hypovolemia, diarrheal illness, and intolerance to enteral nutrition. Then studies of SGLT2 minutes. Yeah. So just give me 2 minutes. Yeah, AGL2 inhibitors in patients undergoing PCI. Again, you can see that some good studies, restenosis after is a big concern in patients undergoing PCI. This is a study of some 377 patients with type 2 diabetes and AMI undergoing PCI. Again, the primary outcome was adverse cardiovascular events defined as cardiac death, liver infarction, and heart failure related to ISA. Again, in this study, the glycemic control was similar, but the incidence of stent restenosis related MACE was higher in patients who were not on SGLT2 inhibitors as compared to patients who were on SGLT2 patients. So again, there's an observational analysis which again they found that AGL2 inhibitor continuation compared with discontinuation was associated with a significant 45% lower in hospital mortality as well as a small decrease in the length of hospital stay. But then this was an observational study, and there was also a confounding indication where the AGL2 inhibitors was only used in the healthy people. So basically, coming to the last slide, the 2024 update of the ADA has recommended SGL2 inhibitors to be initiated or continued during hospitalization and upon discharge in most patients with type 2 diabetes hospitalized for heart failure. To summarize, the use of oral drugs in hospitalized patients often requires modification or temporary discontinuation with a possible transition to insulin therapy to achieve a better glycemic control and reduce the risk of complications. And the patient's overall conditions, including the renal hepatic status, nutritional status, and the potential for drug interactions, must be carefully considered before we initiate any or continue any OADs. Thank you so much for your patient hearing.
Thank you, Dr. Mithil. Are there any questions from the audience?
I guess they have covered everything, whatever
Yeah.
is required for diabetes.
Yeah.
Compared all the basal insulin, but the shorter acting wheeled insulin, what is the data? Insulin. Like overactive advantage, you can be immediately after wheeling. Extra period. Shorter insulin. Patient has hypoglycemia, then we use analog. As ADA clearly recommends, type 1 patient, if they can afford, they should be on analog. Whereas NPH has peaks, and regular human insulin also has and delayed action. So if you are worried about hypoglycemia, then it is better to use analog. Otherwise, if you have seen NPH and regular insulin, there is not much of difference between the analog and wheels. So to add the practical aspects of giving analog, we did a survey into the hospital, and what we found out, the hypoglycemia was because of inadequate food intake or not timely food intake allocation. There was a mismatch of insulin injection with the food. So giving a regular insulin creates a problem there. So that's why one of the fast-acting analogs or analog insulin is preferred, which can be given after food.
So that is what and there was an internal recommendation which we did, that this should be used in the patients who think are prone for hypoglycemia, not eating, having vomiting. These aspects actually guidelines will recommend, but we have to find out what are your challenges in your hospitals. Accordingly, you have to plan your therapies. Absolutely. That's why I said 20 minutes. Nurse doesn't have time. Patient has already eaten the food. These are things which we'll have seen very commonly seen. So that's why we have to come up with a smart solution and give the insulin something which can be given after food.
It is better, but in wards, many times they say the patient has already taken the dinner. They check post dinner.
So then what you will do? So that's why something which can be given. In fact, the analog insulin can also be given after food. So there's not a problem. That's why advantages. That's why I use analog insulin and keep one insulin. They don't know many names. If you see regular insulin, then this insulin and that insulin also confuses the staff a lot. They're not well trained in insulin. Remember that. All these practical aspects have to be kept in mind once you plan any therapy or plan any protocol.
Post meal correction in the hospital stay, what are the guidelines? I understand the pre meal correction is always best. You want to up titrate next day or something.
Yeah.
But in the same day, is there any guidelines for post meal correction?
Means after the patient is eaten and then you do the blood sugars.
And sugar are like so 300. We have to assess next day. What is the insulin sensitivity factor? And then that is fine. But is there any role of doing anything? Correction doses are usually pre-meals. And so there is no post meal correction.
So post meal correction will happen only with the next blood sugars. Now you have a post lunch high sugars, then you have to look at the pre-dinner and correct that. That is what will happen to the patients. That will lead to a lot of hypoglycemia if you try to, because there will be mismatch of insulin and the food peak. So we never there's no recommendation of post-prandial correction. That's why there's no recommendation. Stacking. Yeah. Any questions about orals, insulins? Yeah. Yeah. So see, the lot of studies which have been done on CGM earlier, they were old generation CGMs, and now you can see the new generation CGMs which are coming. So they have a better practical applicability in the ICUs. Of course, they are getting better and better as the years are going by. So vasopressors, all these medications, they will alter your blood sugar. That's why I said currently we don't have a straight recommendation of using a CGM in the hospitalized patients. That's why hybrid mode is recommended, that you calibrate your this one with your point of care blood sugar. Overestimate hypoglycemia, they will overestimate hyperglycemia as well. Both they will overestimate. That's why point of care sugar is required to actually balance it out. But we will have soon more studies as your generation of CGM will improve. You will see it coming out, in the clinical practice. And also, as I said, your recommendations for using the automated devices also will increase. Like maybe you will see the disposable subcutaneous insulin infusion also will come, like use for 10-14 days. You will see soon, not in HOTS type. Use it for 10-14 days. You don't have to give IV insulin. Just use a subcutaneous insulin, and you can keep using for. That's very costly now. You can't use a infusion pump, right? But now you will see those things coming up. This 1-day sensors, 2-day sensors, which will be cheaper for the patients to use. So all these things are in vogue, and I think we have to use it carefully to see how it is working for our patients and how to actually integrate in our clinical practice. Yeah, but as you rightly pointed out, currently FDA has not recommended. You should not use it. You are using it on an experimental basis to see how it is working, but still the guidelines are evolving, the studies are going on, and we should wait for that. Yes. No. So as he rightly pointed out, premixes can be used in the hospital because but only thing problem with the premix is the peak and fall effect. So the hypoglycemia is always a concern with the premix. If you cannot afford basal bolus, then you can use a premix 50-50 easily, as you said, but you will have to take care of the hypoglycemia. And the problem with these insulins is that you have to give 30 minutes prior to food. If you're using a human insulin premix, if you're using analog premix, you can give 5 minutes immediately. But if you're using a human insulin premix, then you give 30 minutes, which is not feasible in the hospital. So there will always be a mismatch of a food and an insulin peak, and there will be a risk of hypoglycemia. And that is very critical. So that if you're sure that your nursing staff is in the small settings, probably you will be able to use it. Larger settings, big corporate hospitals becomes very difficult because they are overloaded with the work. And that's why we always think that premix is a big challenge using it there. In your small nursing homes, 10-15 patients, where two nurses, they'll be able to handle. That's not a problem.
Inpatient setup, we can advise a patient to spend no issues. At least 1 week, spending for the analog is no issues because one hypoglycemia during the inpatient setup will lead to a lot of issues, risk of mortality up to 1 year, arrhythmia, all those things. So we can advise a patient for the inpatient setup. We can very well advise a patient, and this analog insulin, rapid acting, very ideal. We can prevent the hypoglycemia.
And insulin cost inside the hospital is high. You still spend so much things on so many
other things. And as I clearly showed on one of the slides, if you were there or not, 20% compared to 64% hypoglycemia in pre-mixed insulin. And the glycemic control was similar because they were treat to target trials. Otherwise, it is difficult to match the food timing and twice daily dosing, whereas basal bolus becomes more easier in hospital setting. So only if the calories are more.
Most of the patients, 80 to 90% energy through those patients.
Then you have to do carbohydrate counting, and then insulin sensitivity, as Dr. Mohsin has pointed out. For 1 gram of carbohydrate, how much insulin is required, or 10 gram of carbohydrate, what insulin dose in that patient, 1800 divided daily total daily dose. That is a complex calculation then.
Steroid one is little tricky when they come for chemotherapy and they give 12 milligram dexamethasone, sometimes 3 days of dexa.
Yeah, so again, basal bolus would be preferred, and sometimes NPH is preferred. Yeah, for those peaks. Yeah, so you have to continue NPH because it coincides well with that. Yeah, so intermediate acting, it is better to give NPH.
If you want to give oral, there's a glycoside is
So see what happens is with a steroid like prednisolone, NPH suits very well. You can give that. You always said that you can give a short acting. Give it pre-lunch because post-lunch and pre-dinner sugars are going to go high. So there you can use a short acting one. As sir said, you can use an extended release glycoside. That also works very well. But for dexamethasone, multi-dose steroid like dexamethasone, NPH will not work. It has to be basal bolus. You cannot manage with any oral agent or only with NPH. You have to use basal bolus for those 3 or 4 days.
stable mild diabetes don't accept 3 days that will be on insulin. They will practically give little bit more OHs like DPP4 inhibitors or increase the
The hypoglycemia risk is high. Once you withdraw the steroid and there's a stacking effect, they will get hypoglycemia. You can use a long acting agents then like glimepiride. There 2 milligrams or 3 milligrams, one dose. But don't give in the, if you're giving one dose of steroid, just give in the morning. But for multiple dosing, this it's your challenge. You have to use at least basal bolus or maybe one basal plus something like that. Like you give a pre-lunch bolus, rapid acting pre-lunch because you always see this hyperglycemia happening in the post-lunch and pre-dinner.
So, I would like to extend my heartfelt thanks to the chairperson for this workshop, Dr. Urvi Maheshwari ma'am and Dr. Seema Bagre ma'am, for their invaluable presence and support today. And I would request them to felicitate the speakers. Dr. Vimal Pahuja, Mumbai. Dr. Mohsin Aslam, Hyderabad. Dr. Mohsin Aslam. A big round of applause for all our speakers for the workshop today. Dr. Akshay Kothari. Dr. Mahendra Patel. Dr. Firdos Sheikh, big round of applause. Dr. C. Muralidharan, Dr. Vinod Methil, I would request all the speakers and our chairperson for a group photo, please.
We request everyone to join us in Delhi Hall. We have a very interesting speaker, Dr. Anil Boraskar, sir, giving